Hi, good morning. Let's begin now. So we'll start with a prayer po.
Lord, I offer my life to you, everything I've been through. Use it for your glory, and Lord, I offer my days to you, lifting my praise to you as a pleasing sacrifice. Lord, I offer you my life. Let's sing it. Lord, I offer my life to you, everything I've been through. Use it for your glory, and Lord, I offer my days to you, lifting my praise to you as a pleasing sacrifice. Lord, I offer you my life. Things in the past, things yet unseen, wishes and dreams that are yet to come true. All of my hopes and all of my plans, my heart and my hands are lifted to you. Lord, I offer my life to you, everything I've been through. Use it, Lord, use it for your glory. And Lord, I offer my days to you, lifting my praise to you as a pleasing sacrifice. Oh, yes. Lord, I offer you my life. Sing it together. Lord, I offer, and Lord, I offer my life to you, everything I've been through. Use it, Lord, use it for your glory. And Lord, I offer my days to you, lifting my praise to you as a pleasing sacrifice. Lord, I offer you my life. Lord, I offer you my life. Oh, yes.
Hi, good morning. Before we begin, pa-on muna ng mga videos po nila. Ayan, let's have the online kamustahan muna. How's your morning, Ma'am Zaniska?
Okay naman po, sir. Thank you.
Ayan. For sure, great ang morning mo. Kaka-breakfast mo lang ba?
Yes po.
Na, that's nice. Anong breakfast mo, ma'am?
Ano po, ano, Carabao Tapa.
About Tapa. Bicol ba yan?
Di ko po alam kasi yung lola ko po Bisaya kaya hindi ko po sure kung sa kanila or sa
That's nice.
Opo.
Thank you, ma'am, for sharing. I'd like to ask, for sure hindi to pangalan ni Peter Calaw. Tama ba? Hi, ma'am. How's your morning? Great naman ang morning ni ma'am.
Yes po.
And that's nice, ma'am. Na, kasi whenever I ask my students na how's your morning? Kasi like, ano talaga, triname ko sila na dapat hindi ka sasagot ng okay lang. Kasi unfair kasi yun sa mga taong hindi na po nagigising. So, we need to be grateful always. Tama? Ayan. So, dapat yung mga superlatives like ecstatic, na amazing ang morning ko, sir, no? Great ang morning ko, mga ganon, no? So, para ano lang po, no? Be thankful always. Yes. Na, I'd like to ask, ayan, hello, Miss Buban. Miss Buban? How's your morning, Miss Buban? Andyan ba si ma'am? Ayan, wait lang ha. Siguro walang audio si Ma'am Buban. I-chat mo na lang, ma'am. Or pa-heart react na lang, Miss Buban. Ayan, kung nandyan ka talaga. Paramdam naman, Miss Buban. Ayan, I'd like to ask Miss Obilio. Hello, Ayun, si Miss Buban. Hi, ma'am. Miss Obilio, how's your morning?
Good morning po.
Good morning, ma'am. How's your morning?
It was great, sir, actually.
Great talaga. Kaka-breakfast mo lang ba, ma'am?
Yes po, sir.
Kaya great ang morning mo kasi kaka-breakfast mo lang. So, iyon. Hello po na Miss Buban. Hi, sir. Great morning po. Ayan. So, pwede pong mag-breakfast ha. Pwede mag-breakfast na while listening. Walang problema sa amin yan. Ang importante na you have the comfort na kahit nasa bahay ka. And then, ayun po. So, let's begin na. So, we're done na with the atrial fibrillation po natin. And then, we'll proceed na po sa ating, mga, of course na yung mga ventricular problems natin. So, is my audio clear ba? Ayan, on your end, na? Clear naman, clear. Kasi wala muna akong microphone ngayon. Ayan, puro lang, medyo of course, nasa tablet po tayo ngayon, na? So, sige. So, let's have the first topic known as the monomorphic ventricular tachycardia. With monomorphic ventricular tachycardia, guys, na pag sinabi natin mono kasi, meaning one form. Meron kasi tayong tinatawag na polymorphic. So, pag sinabi kong polymorphic in multi-form. So, pag, let's say thumb siya, isang itsura, ang tawag doon monomorphic in one form. Pero mas delikado pa rin po yung tinatawag na polymorphic po natin. Again, guys, ang topic po natin ngayon, it's more of the ventricular problems. Kasi tapos ka na sa sinus, tapos ka na din sa what? Sa atrial problems. So let's proceed na sa ventricular problems. Now, sabay-sabay tayo. Everybody say monomorphic.
Monomorphic.
Ayan, thank you so much. Now, when we talk of vita kasi, guys, pwede kasi siyang may pulso at pwede rin po siyang walang pulse. Na in short, pwede siyang may BP at pwede rin po siyang walang BP. Na take note na lang po natin yan. Kasi pag VTAC, ang iniisip ng iba ay puro siya pulseless. No. Meron po tayong mga tinatawag na pre-arrest or meaning to say may pulse pa ang patient natin before siya magpatuloy na sa tinatawag na jackpot round, which is na to become unconscious na po. Syempre ayaw nating maging unconscious ang patient. Gusto natin conscious lang siya. Kasi ayaw natin mag-perform ng tinatawag na compressions, 'di ba? Pero kung okay naman, kung perfect naman talaga yung compressions mo, guys, there's a saying kasi having poor CPR is having a no CPR at all. Meaning pag bad CPR, meaning no CPR at all. So meaning, wag ka na lang mag-exert siguro ng effort kung poor lang din naman pala yung yung CPR mo kasi poor din ang outcome. Alam mo yung energy ay masasayang lang, na yung strength mo ay masasayang lang din. So when we say monomorphic ventricular tachycardia, so we have a rate here, we have a heart rate, no? Depende yan. So meaning kung may heart rate, malamang may BP si patient kasi may pulse si patient. The rhythm here, guys, is basically regular. Kasi kahit sabihin natin wala po siyang P, pero meron naman siyang R. O, ito, R, 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 R. Di ba the same po ang kanilang distance? So ang tawag natin doon, okay, it's okay, regular. However kasi, wala po siyang P-wave, pero meron naman siyang QRS, which are basically widened. Naalala ba natin yung discussion kahapon? Di ba? Pag ang QRS, okay, is normal, you document it. Pag narrowed naman siya, it's SVT. Pero pag, okay, widened naman po siya, ang tawag natin doon, ventricular tachycardia. So once again, guys, pag isang itsura niya, ang tawag doon monomorphic. Pero pag madami namang itsura, ang tawag doon, it's polymorphic. If that is in multiform, kaya nga poly, in multiform po siya. Obvious naman po sa ating ECG tracing, di ba, na masyadong magulo, ang tinatawag na polymorphic ventricular tachycardia. And usually guys, nagkakaroon ng tinatawag na okay, unconsciousness ang patient natin dito. Magiging pulseless ang patient mo din. Na? So depende din talaga sa case ni patient yan. One thing's for sure, ito talaga ang pinakadelikado, si polymorphic ventricular tachycardia po natin. Now we have a heart rate of 150 to 300 beats per minute. Na? Or basically, typically 200 to 250 ayan, beats per minute. And then, with polymorphic kasi, since in multiform po siya, ang dami kasi mga types na tinatawag na polymorphic ventricular tachycardia. Pero ang pinaka-common guys, no, this is a French term. May idea na ba kayo doon? Anong tawag natin sa French term na yon? It's really torsa de poids. Ito yan na. Ayan. Here are examples kasi na tinatawag na polymorphic ventricular tachycardia. Pero ang pinaka-common talaga guys, which is a French term known as your the torsa de poids. Hindi siya torsades de pointes ha, but rather it's torsa de poids. Sige nga, kayo nga, repeat after me. Please say torsa de poids.
Torsa de poids.
Torsa de poids.
Ayan, thank you so much. It's torsa de poids. Ito namang nababasa nyo na Brugada syndrome. Diba since this is a syndrome, these are collection of symptoms. So pag sinabi kong collection of symptoms, guys, na yung Brugada syndrome natin, ito yung reason kung bakit nagkakaroon ng stroke sa less than 18 years old. 'Di ba ang mga stroke kasi ay very common na sa mga pwedeng sa mid-adult, no, pwedeng sa late adults, 'di ba? Pero pag on teenage years po, yung mga kabataan na reasons ng stroke ay yung Brugada syndrome. Ako naalala ko to dati, kaya nga ako nag-nurse kasi alam mo yung sa Jessica Soho na segment na nag-discuss sila regarding Brugada syndrome. Tapos napalingon lang ako, na. Tapos parang andun yung parang calling na parang okay, so masarap palang maging nurse. Ayan. Pero dapat sa labas pala, no? Masasabi natin masarap maging nurse sa labas pala. Pero pag sa Pilipinas, it's really challenging, 'di ba? Like every day sa battlefield, no? Kahit hindi masyado ganun kalakihan yung yung sweldo, pero sige lang, ang plastic, 'di ba? Sige lang na. Yun naman talaga yung calling natin 'di ba? Yun yung mga pinaka-plastic na maririnig po natin. Pero well, since this is a training ground, yung final patients pa rin natin, guys, yung sa abroad pa rin. 'Di ba? Yun talaga yung goal natin 'Di ba? To serve Filipino people po, or let's say Filipinos for 2 years lang. And then the rest po is history. Dapat mag-abroad. Sino ba dito ba, guys, ang nangangarap mag-abroad? Ayan, can I see heart reactions po sa nangangarap mag-abroad? Andun pa rin yung mga pangarap nila. Yes, marami pa rin po. Yes, dapat lang. 'Di ba? Kasi yung isang year natin, guys, na sahod dito sa Pilipinas ay parang 1 week lang ata. Parang 1 week lang ata pag nasa States ka na, OA na. Or siguro sige sabihin natin 1 month, o 'di ba? 12 months na. Tapos makukuha lang pala sa 1 month na nasahudan. Tapos pag nasa abroad ka na, grabe lang talaga. Like nakaka-land mo lang, let's say, sa US, biglang pupunta na sa apartment mo yung mga mag-offer ng mga cars, 'di ba? Ng mga bahay, yun yung mga nangyari sa mga friends ko din. So, we have your the polymorphic ventricular tachycardia. Ipakita nga natin, sir, sa tinatawag na moving ECG po natin. So guys, as you can see sa ating monitor po, ang tawag dyan, di ba, single form kasi siya. Na one form lang po siya. So anong tawag natin dito? It's a monomorphic ventricular tachycardia. na pag isang form lang. Pero pag marami na po siyang form, ayan, pag marami na po siyang form, ang tawag po natin dito, it's the polymorphic ventricular tachycardia. Okay po? This is more dangerous, guys, na as you can see sa monitor po natin, ang tawag dito, it's your torsa de pois. Kasi alam niyo ba, na just so you know lang, your torsa de pois, ang pinaka-reason niyan is bumaba ang magnesium sa katawan mo. So nagkaroon ka ng hypomagnesemia. So brought about by hypomagnesemia, ayan, may kita natin ang manifestation, ang ECG niya magkakaroon ng twisted points. That twisted points kasi ang tawag doon, it's your torsa de pois. So meaning to say, ang treatment po para mawala ang torsa de pois is your what? Ano kaya? Any idea? If that's brought about by hypomagnesemia, great po, Ma'am Zaniska. Ayan, it's magnesium sulfate, na ang drug of choice po natin dyan. Alright? Ayan, now aside from, discussing polymorphic ventricular tachycardia, ayan, let's proceed na sa ating mga cardiac arrest. So pag sinabi kong cardiac arrest, although yung vita kasi natin can be a cardiac arrest pag walang pulso. Lahat naman ng nag-cardiac arrest, guys, if pulseless si patient. Ano nga yung sabi ko kanina? Ang VTAC natin pwede siyang may pulso or pre-arrest. Pwede rin po siyang walang pulso or baka nag-cardiac arrest na ang patient natin. So again, ang i-discuss ko, since na-discuss ko na si VTAC, hindi ko na siya i-discuss, VFib, no, asystole, then we have the PA. So let's first discuss your ventricular fibrillation. Guys, with your ventricular fibrillation, kasi po, ayan, this means, a sudden cardiac death experience. A sudden, cardiac, death experience. Now, if this is the sudden cardiac death experience, patay ba ang patient natin? Yes, patay na patay ang patient natin. Pero hindi siya patay na patay sa'yo. Na literally patay talaga siya. Pero since magaling ka na nurse, magaling ka na doctor, at napansin mo na nag-VFib pala ang patient, then, syempre, na-expected po na you're gonna activate your code. Ano nga yung code natin, guys? Pag cardiopulmonary arrest, it's your code blue. Code blue po, it's your cardiopulmonary. Meaning may problema sa heart, may problema din sa lung si patient. Kaya pag narinig mo ang code blue to ER bed 1 please, or code blue to ICU, bed 1, meaning kailangan na po ng tinatawag na high quality chest compressions since that is a cardiopulmonary arrest. Now, with ventricular fibrillation, obviously wala po talaga siyang heart rate, na it's absent. The rhythm here is what? No, chaotic in nature. Next, no, there's no P wave, no, there's no QRS, wala din po siya. Ayan, so para siyang mga worms, no? Pwede siyang maliliit na worms, pwede rin po siyang malalaki na worms. Why? Kasi when we talk of ventricular fibrillation, guys, na ang pinakaano talaga, pwede kasi siyang malaki, which is the coarse VFib. Meron din po siyang fine. So pag sinabi po nating fine VFib, mga maliliit po na ventricular fibrillations po natin. So ulitin ko lang ha, pag sinabi nating coarse, mga malalaki. Pag mga maliliit po, we have the fine. Kaya nga guys, if ever po, no, let's say ang patient mo ay nag-asystole, you need to maximize your asystole 5 to 10 times. Why? Akala mo straight line. Yun pala pag zoom mo, biglang gumanito. So hindi talaga siya asystole, but rather meron siyang fine ventricular fibrillation. I keep on telling my students na we need to maximize just to make sure na if that's really a shockable or a non-shockable one. Guys, based sa discussion natin kahapon, ano nga yung mga shockable rhythms natin? Ano yung mga shockable rhythms natin based sa lecture kahapon? Sige nga, pa-unmute na lang po. Yes, thank you, ma'am. So we have the VFib, and then we need to be very specific. It should be pulseless. Tama po si Ma'am Louise. Pulseless ventricular tachycardia. Dapat sabihin natin na pulseless. Okay? Kasi ang VTAC, pwede siyang may pulso at pwede rin po siyang, walang pulso. Now, aside from your VFib po, huwag kalimutan ng VFib. Kalimutan mo ng lahat. Na? Kalimutan mo ng X mo. Huwag lang si VFib. Why? Kawawa si patient. And then, di ba, based sa duty nyo, napansin nyo ba pag nag-V-fib si patient, pwedeng na okay, tas maya-maya biglang babalik na naman. Ang tawag doon refractory. Di ba may mga nababasa tayong refractory ventricular fibrillation, meaning bumalik ang tinatawag na ventricular fibrillation po natin. Alam niyo ba, aside sa natagalan kasi ang management, pwede rin kasi siyang brought about by drugs or brought about by that emergency drug, which is the epinephrine. Guys, hindi kasi pwedeng magkakasunod-sunod ang epinephrine. May mga hospitals po na epi, tapos pronounce that the patient is dead. Actually, AHA recommends na dapat ganito. Epi, tapos amiodarone, epi, tapos amiodarone, epi, tapos amiodarone, and then you can pronounce that the patient is dead if ever kung hindi talaga na okay si patient. Now, if I may ask, ano ba ang maximum doses natin for the epinephrine? Anyone from the group? Anong maximum dose mo? Do we have a maximum dose for epinephrine? Anyone? Actually, guys, ethically wala. Wala po talagang maximum dose. Ayan ha, walang maximum dose. Kaya nga naawa ko sa patients na 3 doses lang. Ay, alamin nyo kung magkano ang presyo ng epinephrine. 'Di ba nasa 75 pesos? Tapos ipagdadamot natin yung 75 pesos na sa kaligayahan ng family, ng relatives na dapat pwede pa pala siyang mabuhay. So may mga doctors akong kakilala na up to 8 doses, na up to 7 doses. Meron din akong very traditional na up to 3 doses lang. Siguro hindi nag-update yon. Na again, naulitin ko lang, for the epinephrine, there's no maximum dose. Okay po? Ayan. Now, aside from your VFib, let's proceed na sa ating next topic known as the asystole. Now, cardiac standstill is the term for your asystole inside the what? The OR. Meron po ba tayong mga OR nurses dito? Or mga surgeons po natin? Meron po ba tayong mga anesthesiologists din dito? Ayan. So, pag sinabi nating asystole, this means cardiac standstill if inside the OR. Pero kasi, pag nasa, let's say ER ka naman, ano nga yung term natin doon? Flat line. Hindi flat-chested. Friend mo yon na flat line ang tawag natin doon. Now, with your asystole kasi, as you can see, sa ating screen po, there's no heart rate. Kaya nga, di ba yung protocol natin, we always check for the pulse of the patient. Nurse, please check for the pulse. 1,000, 2,000, 3,000, 1,000, 4,000, 5,000. Doc, there's no pulse. Okay, you check for ECG leads. Doc, all ECG leads are in place, red, yellow, green. And then I already maximize it, Doc, 5 to 10 times, and it's confirmed that that's what? That's really an asystole. Okay, if that's an asystole, then now we need to start with the high quality chest compression. There will be no defibrillation at this time. And then you give the first dose of epinephrine. Kasi emergency drug ang epinephrine. Pwedeng via inside the vein, pwede rin via inside the bones, ang tawag doon intraosseous. So the rhythm here, there's no rhythm, there's no P wave, there's no QRS. It's plainly flat. So meaning to say, bakit ka magdi-defib? 'Di ba? Maling-mali 'yon yung mga nakikita po natin, guys, sa maalaala mo kaya, 'di ba, sa magpakailanman, bigla silang nag-defib. Tapos biglang nabuhay ang patient. Ang weird, no? Impossible talagang mabubuhay si patient. Guys, mas mabubuhay po ang patient. Pag sinabi nating non-shockable, you start with immediate high quality chest compression. There should be no defibrillation. And simply you give the drug of choice, which is the epinephrine. Okay? Now, aside from your asystole, meron din tayo tinatawag na P-wave asystole. The same pa rin po yan. Mga asystoles pa rin po yan. Okay po? So we have the asystole, then we have the P-wave asystole po natin. Next topic will be the PA. Guys, in your PA kasi, this is actually a situation. From series of arrest ang patient mo, tas biglang nagkaroon ng PQRST. However, wala palang pulso ang patient. Ang tawag doon, pulseless electrical activity, meaning to say, patay pa rin ang patient natin. So, the same pa rin po sila ni asystole, na kung saan we need to treat the reversible cause, lalo na kay PA, kaya ang mga doctors po, tatanungin ka, Mr. Adlawan, bakit kaya nag-PA ang patient natin? So, syempre, kunwari lang ha, kunwari. If you are a doctor, tatanungin ka ng kapwa mo doktor. O, let's say Doc Gonzales, bakit kaya nagkaroon ng PA ang patient natin? So, sasabihin ni Doc Gonzales, Doc, kasi the patient came in with signs of hypovolemia and with signs of what? No, dehydration. So, it might be brought about by the first H, which is your hypovolemia. Guys, alam niyo ba sa PA, 2Hs talaga ang pinaka-common. Ang pinaka-culprit talaga nito eh. Number 1, we have hypothermia. If you are hypothermic, next, if you are hypovolemic with severe signs, let's say severe dehydration, then expected po ang PA or pulseless electrical activity po natin or PA. Sir, ano bang itsura ng PA? For a while lang ha. Ayan, i-demonstrate ko lang. From VTAC, biglang nagkaroon ng VFib. From VFib, biglang nagkaroon ng asystole. From asystole, biglang nagkaroon ng So guys, if we're going to analyze kasi the situation na from series of arrests, bakit biglang nagkaroon ng PQRST? So sasabihin ni Doc na, okay, I think we have achieved ROSC. Anong ibig sabihin ng ROSC? The return of spontaneous circulation. Meaning baka nabuhay na ang patient. So sasabihin ni Doc, okay, Mr. Adlawan, please check for pulse. 1,000, 2,000, 3, 1,000, 4, 1,000, 5, 1,000. Doc, ayan, wala pong pulso si patient. So ang tawag doon, pulseless electrical activity. Pero pag may pulso si patient, ano kaya yan guys? Doc, may pulso si patient, ano kaya yan? With a heart rate of 38, the rhythm is regular. The P waves, di ba? They are clear and they are upright, followed by QRS which is normal. Ano kaya to? Sinus? Brady?
Bradycardia.
Yes, ma'am. It's sinus bradycardia. Yes, na-revive natin si patient pero bradycardic naman. Pero ang importante, at least may pulso na po ang patient natin. 'Di ba? Ayan. So let's say series of arrest. Pag walang pulso, ang tinatawag na PQRST mo, biglang feeling mo nabuhay, pero wala palang pulso, ang tawag doon PA or pulseless electrical activity. Sige. Let's try to recap po na in a moving ECG. Ayan, so it's VTAC. So the heart rate here is 0. The rhythm here is regular. There's no P wave. Now it's more of QRS and it's what? No, widened in nature. If you have a widened QRS, then therefore this is your VTAC. However, we need to be very specific. Is it monomorphic or polymorphic?
Monomorphic.
Monomorphic. Okay, ventricular tachycardia. Next po.
Polymorphic ventricular tachycardia.
Ang galing, na? So basically, guys, we have a heart rate of 0. The rhythm here is what? Na irregular, or basically it's chaotic in nature. There is no P wave na, ayan, yes, meron naman tayong mga QRS pero in multi-form. So ang tawag natin doon, it's the polymorphic ventricular tachycardia or the torsa de pois. This is the torsa de pois. Di ba para siyang twisted? Tinwist na ECG. Kaya nga, T for torsa, T for twisted points. Next po.
Asystole.
Okay, so we have the word, asystole. Now, before po tayo mag-asystole, guys, ano nga yung natin, protocols? Name one. Check for?
Pulse.
We check for what? We check for the pulse. Great. Ano pa? Check for? ECG leads. And then, you maximize 5 to 10 times para masabi po natin na nag-asystole po ang patient po natin. For a while, i-off ko lang muna yung camera ko kasi bigla akong unstable ang internet. Okay. Let's continue na with our discussion po. Guys, we will be dividing the scenarios. Okay, we have the pre-arrest, we have the arrest, and then we have the post-arrest setting. Ulitin ko lang ha. We have the arrest, we have the pre-arrest, we have the arrest, and then we have the post-arrest setting. Sir, ano ba ang ginagawa natin on the pre-arrest setting? Alam niyo ba on the pre-arrest setting, dito na po natin ginagamit si ACLS. Tapos pag nag-arrest naman si patient, gagamitin mo na si BLS. However, kasi it should be an intra-hospital setting. Intra-hospital setting po. Pag post-arrest naman guys, dito mo nagagamitin si PCAC. Ano nga ibig sabihin ng PCAC or the post in cardiac arrest? Pa-mute na lang po muna ha. Sorry po. Pa-mute na lang po muna. Ayan, so again, we have the pre-arrest, we have the arrest, and then we have the post-arrest setting. Guys, on the pre-arrest setting, kausap mo pa ang patient. Kasi before po siya mawala ng consciousness. Tapos pag nag-arrest na si patient, malamang hindi mo na siya kausap. Sa post naman po, from series of arrest, biglang nagkaroon ng tinatawag na pulse rate ang patient mo. So that means, nag-post na si patient or post cardiac arrest care dapat. Kasi bakit kailangan may post-cardiac arrest care, sir? Para hindi magkaroon ng stroke ang tinatawag na patient natin. Because stroke here is really common after a series of arrest. Now, let's focus more on the pre-arrest setting. Guys, sabay-sabay po tayo. Everybody say pre.
Pre.
Ano ang gagawin natin, guys? Is it the BLS or ACLS?
ACLS.
It's ACLS. Pag kausap mo si patient, it's ACLS. Pero pag hindi mo na siya kausap, guys, you perform BLS survey. Ang tawag kasi doon mga surveys eh. If the patient is conscious, you perform ACLS survey. If the patient is unconscious, then perform the BLS survey. Now, with your pre-arrest setting, my mnemonic will be the mnemonic vomit. Ayan. Everybody say vomit.
Vomit.
Ayan, thank you so much. Letter V stands for you visualize the patient. Next, there should be verbalization or verbalize. Next, we have the vital signs. You get the heart rate, the BP of the patient, the RR, diba? The temperature is important kasi pag may fever, baka kasi mga COVID complications yan. And then lastly po, we have the O2 sat. Guys, question, what's the normal O2 sat ulit? It's 95 to 100%. Tama po ba? However kasi, if the O2 sat drops to less than 94% na lang ang O2 sat ni patient, your letter O here, that means O2 therapy. Okay po? Now, with American Heart Association, guys, or AHA recommends that if we're going to use nasal cannula, we have the simple face mask, and then we have the non-rebreather mask. Ideally, it should always be the non-rebreather mask. However, kasi hindi naman po lahat ng hospitals ay may non-rebreather mask. So sabi ni American Heart Association, if we're going to use a nasal cannula, it should be at 2 to 4 liters per minute. If that's a simple face mask, guys, it should be at 6 to 10 liters per minute. And then if that's a non-rebreather mask, it should be at 11 to 15 liters per minute. There's actually an update na halos lahat naman dapat ng ER po ay dapat may non-rebreather mask. Meron ba kayong non-rebreather mask sa inyong mga ER? Sige nga, baliktarin nga natin. Kung wala kayong non-rebreather mask, pa-thumbs up nga. Ay, wala nga talaga, na. As in, kaya nga dapat sa ating mga ERs po, dapat may mga non-rebreather mask. Kasi yun po yung nire-recommend po ng American Heart Association na dapat meron tayong non-rebreather mask, especially if that is a case that needs na great oxygen po. Pero hindi kasi sa lahat ng oras ay kailangan ng oxygen. Tama po ba? Anong case nga yan, guys? Ang mga taga-ER, magagaling nito. What's the case? The COPD. Kasi 'di ba, for the COPD patients kasi, their drive for breathing po is pagbaba ang kanilang oxygen. Ang tawag doon hypoxic state. dapat may hypoxia ang patient para giginhawa siya, na, or para magbi-breathe ang patient mo. Kasi for COPD patients, guys, na pag tinaasan mo ang kanilang oxygen, hindi na po hihinga ang kanilang sariling katawan. Hanggang sa magulat ka na lang, akala mo well-rested si patient, well-rested na pala siya for life. So patay ang patient natin. Sa atin naman kasi ng mga normal na patients na wala pong COPD, our drive for breathing is ang pag-increase ng carbon dioxide sa katawan po natin. Napansin niyo ba yon? If hindi ka na humihinga, mataas na yung carbon dioxide sa body mo, then that's the time we breathe. For us normal na mga tao. Pero for COPD patients, no, they breathe only pagbaba na po ang oxygen, and which is good. Kaya never na increase the oxygen levels na like administering yung mga O2 therapy po natin. Diyos ko, dapat low flow lang po ang ibibigay sa may mga COPD po natin. Ayan, dumadami na po tayo, naging 25. Napansin ko lang pag morning madami po tayo, pero pag hapon bigla-biglang nawawala. It might be brought about by internet connection or baka nag-duty talaga yung iba. Meron kasing absent kahapon na 5, I guess, na parang 5 ata sila. I don't know if nag-duty. Walang problema sa akin. Guys, pwede kayong mag-cover up ha. Like, pwede naman kayong humingi ng mga videos, no? Ng mga, let's say, YouTube na mga recordings po. Meron naman kasi. And then, or pwede kang mag-join, no? Next meeting, if ever kung ano talaga, kung sobrang busy mo talaga, na kung saan importante talaga yung certificate din. For me, usually kasi pag online, hindi po namin hawak no ang schedule nyo. Kaya nga 'di ba mas for some no mas nag-enjoy sila pag online kasi the comfort na of their own na din kahit nasa bahay. Yung iba kahit natutulog lang, naka-online, ang importante meron na silang mga certificates. Pero for me kasi kailangan talagang we need to listen para maging updated din po tayo. Real ito, kailangan talagang naka-on ang camera. Medyo year pa eh. Na so, nag 1 year na po ako nung November. Siguro before mag 2 years. Face-to-face na po kami this year. Magbabago yung IATF. Sa Bicol ba nag face-to-face na? Parang kayo ata yung mga totoo napansin ko. Alam niyo ba dito sa Davao until next year? Amazing po. Na and then kasi baka magbago din 'yon, no? Tapos biglang balik na naman kami online. For me, somehow na beneficial naman siya kasi walang gas, 'di ba? Walang mga transportation na mangyayari na pwedeng maligo, pwedeng hindi rin maligo. So ang tanong ko sa inyo, naligo ka na ba? Pero pag sanay ka sa online, guys, na ayan, ligo is what? Na matinding pagsubok talaga 'yan. Pag pag ganitong mga mga let's say month, malamig na ba sa sa Bicol? Malamig ba diyan ngayon? Parang alam ko malamig eh. Pag January, 'di ba? January, February, malamig talaga sa sa Bicol, o 'di ba?
Starting
Tandang-tanda ko
December
pa.
pa.
Starting December, malamig na talaga, ma'am, no? So malamang hindi talaga kayo naligo kasi pagsubok nga talaga ang pagligo din. Ayan, with all the mga fog pa, 'di ba? Ayan, sige pa. So we have the O2 therapy, guys. Careful lang ulit tayo ha sa oxygen. Guys, I have a question. Is oxygen combustible? The answer is no. Na pag oxygen alone, it's not combustible. The perfect statement, it should be oxygen supports combustion. Okay po? Ulitin ko lang. Oxygen alone is not combustible. It only supports combustion. Whenever there's oxygen and there's fire, na, then malamang sabog talaga ang patient po natin. Pero pag oxygen alone lang, hindi naman siya magkukos talaga ng ng fire eh. It only supports combustion. Now, aside from that, aside from letter O, we have our letter M, letter I, and then we have our letter T. Guys, with your letter M, so we have the monitor. You attach the patient to the cardiac monitor, or basically, you attach the patient to your 12-lead ECG. Next naman po, we have our letter I. There should be the insertion. Insertion ng ano, sir? Pwedeng IV insertion. And it should be on the left, okay, brachial vein dapat ha. Left, okay, brachial, ayan, vein. Ideally, it should be on the left brachial vein. Wanna know why? With its close proximity po sa tinatawag na heart ni patient. Kasi 'di ba sa left brachial vein mo, andyan din yung heart mo. Tapos pag nagbigay ka ng emergency drugs and then you're going to let's say raise na the arm of the patient, by flow of gravity papasok na po yan sa heart ni patient. And then your heart will pump the said blood na going to the systemic circulation. Along with it is your Na syempre yung mga medications po na ibigay. And usually kasi mga emergency drugs yan. Now, if you have 2 failed attempts, sulat ko lang ha. If you have 2 failed attempts for the IV insertion, guys, you can proceed with IO or intraosseous. Your intraosseous po is inside the bone of your patient. So mamaya may video po ako na sa intraosseous. Sa IV, yes, meron din akong video. Just to recall lang, mga recap lang po tayo. So we have the IV again ha. First po, kasi 'di ba during emergency cases, IV talaga ang pinaka the best eh. The fastest talaga siya pag emergency. However, if you have 2 failed attempts po, ang tawag natin doon IO or intraosseous. And then aside from that, we have your letter T, and that's the treatment. Sir, on the pre-arrest setting, guys, ano ba yung mga common? Number 1, we have the sinus bradycardia. Common yan. Next, we have the ventricular tachycardia but with pulse. Common din yan. Next, we have the SVT. Common din po ang mga ito. So ito muna yung ititreat ko ha. Si sinus bradycardia, VTAC with pulse, and then we have the SVT. Tapos pag natapos ko na yung i-discuss, magbe-break na po tayo. Now, we have the sinus bradycardia first. Guys, everybody say sinus bradycardia.
Sinus bradycardia.
Thank you so much. Pag sinabi kong sinus bradycardia, AHA recommends na you need to check the patient's BP to know whether the patient is stable or unstable. Now, if the patient's BP, guys, is greater than 90/60, meaning to say it's stable. Okay po? Kasi sabi ni AHA, para masabi mo kung stable ba ang patient mo, i-check mo ang patient's BP to know stable or unstable ba siya. If the patient's BP, guys, is greater than 90/60, ang tawag doon stable, sinus bradycardia. Now, no need for you to treat the patient but simply observe the patient lamang po. Why? You will observe the patient, baka kasi biglang magkaroon ng dysrhythmia ang patient or baka biglang magkaroon ng mga irregularities si patient. So therefore, not just observe the patient. Sir, paano ba obserbahan ang patient? Do I need to monitor the vital signs? Malamang na to check the stability of your patient, diba? And para masabi natin na may continuity of care talaga, so we always check for the vital signs. Now, aside from your the greater than 90/60, what if less than 90/60 po ang tinatawag na BP ng patient natin? Anong tawag natin doon? Anyone from the group? It's unstable. It's unstable, sinus bradycardia. Now, to patients suffering from unstable sinus bradycardia, guys, we always treat the patient po. So, you treat the patient now. Paano ba mag-treat ng patient? So, my mnemonic will be at the. Bakit at the, sir? Your at the means all trained, doctors are excellent. Lahat naman eh. Kahit hindi doctor, basta trained nurses, malamang they are excellent. Diba? You are born for greatness. We're not dealing with papers again. We are dealing with lives here. Kaya ako, honestly, gusto ko talagang ma-update from time to time. Lalo na sa BLS, ACLS, Kaya chine-check ko always na every now and then yung email ko kung may mga updates po sila. So far wala pa naman. Sana next week may mga updates na naman po sila. Don't worry kasi i-update po kayo ng WePump sa Facebook po nila. Kung ano yung mga updates po, i-share po yan ng WePump. Tapos kayo na din bahala mag-share na share the good news guys na regarding WePump. Kasi proven and tested na po lahat ng mga certificates, lahat ng cards na matatanggap nyo ay legit at magagamit talaga abroad. Now, all trained doctors are excellent, known as you're the ATDE. In case lang guys na unstable po ang BP ng patient natin tapos may sinus bradycardia si patient, the first drug of choice will be your atropine sulfate. What's the dose? At 0.5 milligram times 6 doses with a maximum dose of 3 milligrams given every 3 to 5 minutes po. So again, we have the first drug of choice which is for the atropine sulfate. Next, we have the transcutaneous spacing. Ayan, transcutaneous spacing. Next, we have the dopamine. Ang dopamine kasi natin guys, 3 doses kasi to eh. Mamimili ka lang sa doses na to. We have the renal, we have the cardiac dose, and then we have the vasopressor dose. Pressor. Pag renal dose guys, we have it at 2 micrograms per kilogram per minute. Pag cardiac dose naman, we have it at 5 micrograms per kilogram per minute. Pag vasopressor dose, it's 10 micrograms per kilogram per minute po. Guys, everybody say renal.
Renal.
For your renal po, ang tawag doon renal dose, 'di ba? Paiihiin mo si patient. Kasi ano nga ang sabi natin, a good cardiac output must have a good renal output. Pero you will be wondering, bakit may oliguria si patient? Bakit scanty lang yung urine niya? Something is going on sa kanyang katawan. Kasi hindi niya na-excrete. Kung ano man yung binigay mo, bakit hindi siya fully na, or let's say kahit close to, yung mga binigay po natin or the input. Di ba dapat kasi congruent dapat si di ba? Si input at saka si output. Tama po ba? They should be directly proportional to one another. Kung increase yung input mo, dapat increase din yung output mo. Pero pag nag-increase ka ng input, tapos wait lang, bakit yung output ko, ba't parang wala? Something is going on. Baka may congestion si patient. So we have the renal dose. Pero kasi, in this scenario, baba na nga ang BP mo, tapos nagbigay ka pa ng renal dose, mas lalo pong bababa ang BP ni patient. Ang gusto ko lang na i-emphasize dito guys, is yung 3 doses natin. Do not forget them. Okay po? Kung gusto mong paihiin, you give the renal dose. Kung gusto mong mag-focus lang sa heart rate, which is good, kasi bradycardic si patient dito eh. Kung magfo-focus ka, malamang you give the 5 microgram per kilogram per minute. Your vasopressor kasi guys, that focuses more on the BP of the patient. Kaya nga vasopressor VP. BP ni patient. Kung gusto mong pataasin ang BP ng patient, kaya nagbibigay tayo ng dopamine. Ang tawag doon, the vasopressor dose of your dopamine. Okay? Usually, ginagamit natin ang vasopressor dose niya after an arrest setting. Let's say, biglang may signs of life na ang patient mo may pulso na, pero sir, masyadong baba ang BP. Don't worry, magbibigay tayo ng pampataas ng BP. Usually guys, ang protocols ng hospital, i-check muna ang lungs. Baka kasi may mga crackles tayo. 'Di ba? Crackles kasi or rals, there are signs of what? Hypervolemia. Kung may hypervolemia ka, tas magbibigay ka pa ng more and more of fluids po, mas lalong malulunod ang patient. Kaya pag check mo na tinatawag na lungs, tapos wala namang hypervolemia si patient, then that's the time na magbibigay po tayo ng fluid resuscitation. Nagfa-fast drip po tayo ng 1 to 2 liters of yung mga let's say mga isotonic po natin. Okay? So we have the vasopressor. Next po, we have the epinephrine. Now, with the epinephrine kasi we have the initial dose. And then we have the maximum dose. Initial dose should be at 2 micrograms per minute po. Tapos ang maximum dose po natin will be at 10 micrograms. Ayan, per minute. So ulitin ko guys ha. Initially, no, for epinephrine, it's 2 microgram per minute. Tapos maximum dose niya will be at 10 micrograms per minute. The mnemonic guys, at the, or meaning to say, all trained doctors are excellent. If ineffective po ang letter A, you proceed with letter T. If ineffective naman ang letter T, you proceed with letter D. Pag ineffective si letter D, liter sand, ayan, pag ineffective si dopamine, you proceed with epinephrine. Okay po? So the mnemonic is at the. Sige nga, everybody say at the.
At the.
Ayan, thank you so much. No? So we're done na sa ating sinus bradycardia. Now, let's treat po your VTAC with pulse. Treat natin na si VTAC okay, with pulse. Now, paano ba mag-treat ng VTAC with pulse, sir? Again, you check the patient's BP. If the patient's BP is greater than 90/60, ang tawag doon, okay, it's stable. Ayan, ventricular tachycardia with pulse. My mnemonic will be the 2-piece po. Bakit 2-piece? Pag stable po, 2-piece. Pag unstable kasi, 2S's dapat yan. So pag 2-piece po tayo, okay, the first P will be, ayan, physician consultation na agad. Physician consultation. In short, you seek, di ba? Maghanap ka ng consultation. You seek physician consultation. Ito yung pinaka-importante dito. So tatawag ka kay doc. Doc, ang patient po natin nagkaroon ng VTAC pero may pulso naman, doc. So anong gagawin po natin? So si doctor guys ay mag-order ng tinatawag na pharmacologic therapy. So we have the pharmacologic therapy in which DOC is the drug of choice. Ayan, DOC guys, drug of choice will be the amiodarone. Your amiodarone is actually a class 3 antiarrhythmic drug which blocks, ano yung iba-block niya? The sodium, the potassium, and then we have the calcium channels. So ulitin ko lang, the drug of choice in treating your ventricular tachycardia with pulse, it's the amiodarone. This is a class 3 antiarrhythmic. It blocks sodium, it blocks potassium, and it blocks the calcium channels. Now, matanong ko lang, sir, what's the dose for your amiodarone? Walang ibang sagot. It's half of the full dose, meaning it's 150 milligram over 10 minutes. Okay po ba? It's 150 milligrams over 10 minutes. This is the perfect dose po in treating your ventricular tachycardia with pulse. Kasi pag nag-VTAC si patient na walang pulso, i-full dose natin siya ng 300. Meaning half lang po ito ng full dose, which is 150 kasi may pulse naman ng patient eh. Pero pag wala na yung pulso, full dose tayo, which is times 2, which is 300 milligrams po. Okay? Ayan. Now, what if naman po unstable, less than 90/60 ang tawag natin dito? We have an unstable, ayan, ventricular tachycardia na, with pulse. Guys, ang gagawin po natin dito, so pag unstable, everybody say unstable.
Unstable.
Thank you so much. So when we say unstable po, so number 1, we need to sedate the patient. After sedating the patient, we're going to perform synchronized cardioversion. Okay? Now, sir, ano bang ginagamit nating pang-sedate? Anyone from the group? That starts with letter D. Diazepam. Alangan naman diatabs. Syempre hindi diatabs, na. Pero for me masarap pong matulog after diatabs. Kasi malamang okay na kasi yung tiyan mo eh, 'di ba? Ayan, so we have the diazepam. Aside from having your diazepam, ayan, we have the midazolam. Next, we have propofol, and then we have the etomidate. Etomidate po natin. Guys, diazepam, midazolam, propofol, etomidate. Isa-isa lang ang ibibigay. Huwag mo pong ibigay lahat. Kasi pag bibigay mo lahat yan, baka sedated na ang patient mo for life. Okay? So mamimili ka lang, diazepam ba, midazolam, propofol, or etomidate. Are you familiar with the word propofol? Are you familiar with the drug propofol? Yes. Ito yung ginamit ni Michael Jackson. This is a potent sedative kasi. Alam niyo ba during the autopsy of Michael Jackson, parang 7 to 8 gallons, na take note ha, gallons na of propofol actually ang ibinigay sa kanya, meaning pang sedate lang kay Michael Jackson. Kaya sikat na sikat yung propofol eh. So etomidate is not common here in the Philippines, but propofol, midazolam, diazepam, they are common here in the Philippines. Now, synchronized cardioversion, ayan, charging at 100 joules. Mamaya ipaperform po natin si synchronized cardioversion. Again guys ha, if the situation is stable, lalo na pag ventricular tachycardia, ayan, syempre ang technique natin will be the 2Ps. Pero pag naging unstable po yan, 2Ss po yung technique natin. Next po, before our break, we have your SVT. Guys, ano nga ang other terms SVT? It's the supraventricular tachycardia, the narrowed complex tachycardia, and then we have here the atrial tachycardia. Naalala ba yung discussions kahapon? Check again the patient's BP. If the patient's BP po is greater than 90/60, ang tawag natin doon, it's stable. Guys, if that is stable, ang gagawin natin, 2 Ps pa rin po tayo. Sulat natin. So we have here the 2 Ps. Now, the first P po is the physiologic. Ayan. Pag sinabi kong physiologic management, if you're familiar sa carotid sinus massage, and then we have the coughing po natin. Carotid sinus massage for 10 seconds. And then coughing for 10 seconds also. This coughing, guys, is for 50 years old, okay, and above. Ayan, 50 years old and above, encourage them, okay, to cough. Pero pag mga 50 years old and below, tapos nag-SVT, ayan, na imamassage lang po natin ang kanilang carotid artery for about 10 seconds po. Now, aside from having your physiologic therapy, we have the pharmacologic. Alam niyo ba ang pharmacologic therapy po natin, guys? Siyempre, we have the drug of choice here. Walang ibang sagot that starts with letter A. Adenosine. Guys, with your adenosine kasi, ayan, alam niyo ba ang adenosine, it should be rapidly IV pushed. Ayan, rapid IV push. Ito yung basic requirement dito eh. Why? Because we have the half-life na of your adenosine for about 10 seconds only. Meaning to say, pag lumagpas ka po ng 10 seconds at hindi mo pa rin naibigay si adenosine, 50% na lang ng efficacy ng tinatawag na drug ang maibibigay mo kay client. Sayang lang din na dapat 100% po ang effectivity nito. Pag 50% na lang, luging-lugi si patient. So dapat you need to rapidly IV push that one for about 1 to 3 seconds. Ganon kabilis po ha. Ganon kabilis, no? Kung pwede nga lang 1 second na naibigay mo na po si tinatawag na adenosine para hindi ka maabutan ng half-life. Kasi let's say 10 minutes na, meaning 50% na lang. Tapos let's say sabihin natin 20 seconds, meaning ano ang half ng 50? 25% na lang ang effectivity po ng tinatawag drug natin. Kaya nakakatakot pag may mga drugs tayo tas may mga half-life, no? Ayan. So aside from the rapid IV push, no half-life, so we have the doses. Guys, may technique ako dito. Everybody say adenosine.
Okay.
Diba sounds like adeno-6? Why? Because we have the 6, 12, 12. Meaning this is the first dose, the second dose, and then we have the third dose. 6 milligrams, 12 milligrams, and then we have the 12 milligrams. This should be given every 1 to 2 minutes if wala pa rin pong effect ang first dose natin. However, kasi sa first dose pa lang, no, yung 6 milligrams pa lang guys, babagal na po ang pagtibok ng puso ni patient. Ano nga ang problema natin kay SVT? Siyempre, no, 170, di ba? 150 and above ang heart rate ni 6 milligrams na rapid IV push. Na? Tapos, remember the half-life na of 10 seconds. So, dapat rapidly IV push for about 1 to 3 seconds. First dose pa lang po, mau-okay na si patient. Pero pag hindi pa rin siya na okay, you wait for 1 to 2 minutes and then you give the second dose which is 12 milligrams. Guys, may share ako sa inyo ha. Nakita ko lang to sa Facebook eh. Sa Italy ata yon. Si patient po nagkaroon ng 175 na heart rate. Meaning to say, patient is manifesting ano po, SVT or the supraventricular tachycardia. So may ginawa na maneuver po ang doktor. Ang ginawa niya, it's a form of vagal maneuvers. So kumuha siya ng syringe, syempre walang needle. Kasi kung may needle yan, Guinness Book World Records yon na tutusukin niya yung dila niya. Grabe ka. Syempre walang needle. Tapos alam niyo bang ginawa? Pinablow niya. Pag blow ni patient, no, nag-wait lang sila ng 15 seconds, nag-count sila eh. Ang narinig ko kasi 15. Nung sinabi niyang 15, biglang pinataas ang what, no, ang kanyang leg. So meaning, habang nagka-count muna sila guys, nakaganyan muna si patient, tas nag-blow si patient. Tapos, nung 15 seconds na, tinaas na nila ang legs ni patient pero naka-blow pa rin sa syringe. Meaning, nag-vagal maneuver si patient. Na bumagal talaga ang pagtibok ng puso. Kaya na-amaze ako doon eh. Sobra ako na-amaze. Pero ako naman, whenever I feel na parang bigla ako na-anxious, bigla ako naging tachycardic, nagmamassage lang ako eh, ng carotid artery. Minamassage ko lang. Or sometimes, nagdi-deep breathing lang din ako, na nagbabalsalva maneuver as if may tubol. Alam niyo yung tubol? 'Di ba? Ito yung mas matigas. Alam niyo yung igit? Guys, alam niyo yung igit? Ito yung utot na may sabit, 'di ba? Yung napautot ka lang pero tae lumabas. Or napautot ka lang pero parang wait lang, parang mainit na 'yon, na parang tridor. Alam niyo ba na try ko talaga dati yan eh. Taing-tai talaga ako from Manila going to Bicol. Lord, Diyos ko po. Bawal palang tumae doon sa bus. Bawal palang tumae, no? Kasi sabi ko, wait lang. Parang feeling ko hindi ata mawawala yung amoy. Buti na lang may dala talaga akong pabango. Halos naubos ko yung pabango ko. Kasi 'di ba mga judgmental kasi yung tao eh. 'Di ba? Pagkalabas mo talaga sa CR, aamuyin nila, 'di ba? Kung mabaho ba talaga or mabango. However naman kasi based naman kay Kujir sa funda, no, your stool daw guys, yung feces kasi, your stool is actually aromatic in nature. 'Di ba? Amazing, no? It's aromatic. Kaya nasabi ko din sa bagay, may point naman siya kasi kung sarili mong tae, hindi ka mandidire, 'di ba? Hindi pong morning na morning, kakatae mo lang, tae ko nga to. Pero pag ang tae ng iba na amoy mo, bad trip ka talaga. Tama ba? Ito yung sa natry ko sa bus din. Kasi 'di ba, grabe, sobrang tagal kasi. Parang feeling ko nag-UK travel ako, no? Parang feeling ko, alam mo yung ano, basta grabe talaga yung travel papunta Manila going to Bicol. Sobrang toxic lang talaga. Okay? Ayan, sige po. So let's continue guys. So, ayan ha. So we have the first dose, we have the second dose, and then we have the third dose ng tinatawag na adenosine po natin. Well, I guess na it's time na para magkaroon ng break. Guys, we will resume at exactly 9:30. Na i-break muna natin ang mga sarili natin sa camera at saka sa internet. Ayan, sige po ha. I'll see you at exactly 9:30. Mag-breakfast po muna at mag-charge po ng mga gadgets nila. Magpi-play lang ako ng video guys habang nagbi-break po tayo.
COVID-19 has resulted in several important changes to the adult in-hospital advanced life support algorithm. These changes were updated and released by the Resuscitation Council UK on the 26th of March 2020, yesterday. Today, in this simulation, we will present an adult in-hospital cardiac arrest in a suspected COVID patient. There are two overarching principles. Number one, early decisions regarding treatment escalation and not for resuscitation need to be made early and communicated with the team. Two, chest compressions is considered aerosol generating. As a consequence, full personal protective equipment must be worn by every individual in the room before chest compressions is commenced.
We would like to present a 50-year-old gentleman who's come in with a cough, breathlessness and fever over the last 7 days, worsening and being admitted to hospital yesterday. Today he's deteriorating rapidly and the team already knows that they will go all out for him, including resuscitation and intensive care.
John? John, can you hear me? John? John, can you hear me? Can I have some help, please? He's in cardiac arrest. Put out an adult COVID cardiac arrest. 2222.
Adult COVID cardiac arrest in the sim lab.
Analyzing heart rhythm. Do not touch the patient. Shock advised. Stay clear of patient. Deliver shock now. Shock delivered. Pause. If needed, begin CPR.
Hiya, adult cardiac arrest has received a single shock. I'm going to lead, then start chest compressions.
Analyzing heart rhythm. Do not touch the patient. No shock advised. Pause. If needed, begin CPR.
Okay, can we mark something? Okay, and double check you. Yeah, you're good. Okay, thanks. Right, next.
take over, don't worry.
Right, let me just double check you. Yeah, you're good to go.
Okay, let's go in.
Hi, Claire, okay.
Hi, Claire, if you get up to the top end. Okay, so what's the story?
So 50-year-old admitted last night, community-acquired pneumonia, COVID test not back yet, now deteriorated, hypoxic, initially shockable rhythm, shocked, and now in PEA.
Okay, no problem. Can we give some adrenaline if it's PA? Okay, so can we get some adrenaline, please?
Yeah, the adrenaline's here.
Okay, could you take the adrenaline?
Potassium was 3.9 this morning.
Okay, fantastic. So we've done hypotension, we've done hypokalemia, okay. We've done hypothermia. Okay, what are we missing?
Analyzing heart rhythm. Do not touch the
Okay,
patient.
fantastic. So can we do the T's as well? Okay, we'll see.
No shock.
No shock. Carol, you ready to see CPR?
Yep.
Okay, can we just do one inflation just to make sure the chest is rising? Okay.
Oxylog.
Okay, so both sides are going up. It's unlikely to be a tension pneumothorax. Okay, have we got any opportunity for an echo?
There is no echo available.
No echo. I think tamponade is highly unlikely. Okay, what drugs has he had?
So you had some antibiotics about 4 hours ago, nothing else prescribed.
Okay, is there any rash?
No rash, I can see.
Okay, fantastic. And I think
No rash.
thrombosis is unlikely. He's been in for a short period of time only. Carry on CPR. We're going to do a cycle 2 minutes. We'll hear when it's 2 minutes. Okay, you're happy with the airway?
Yeah, just tying in.
Okay, well, if we do get this guy back, we need ITU. So can you check with ITU if they've got any capacity at the moment?
Yep.
Okay. Okay, so...
Hi, is that the ITU consultant?
interrupt.
Okay, I've got a 50-year-old who's COVID positive who's gone into cardiac arrest down on the wards. Have you got any capacity there to take him if we were to get Ross back? Okay, we'll let you know.
Okay, gentlemen, 2 minutes interrupt.
Right, so the ITU consultant will be down shortly. They have got one bed available.
Okay, have we done 2 minutes yet?
That has been 2 minutes.
Okay, can we do a pulse check, please?
Okay, yeah, I can feel a pulse.
You have a pulse, okay, let's do a blood pressure. Okay, if there's any chance of doing an ECG, okay, we should do an ECG. And can we probably at this stage do a gas, okay, just to make sure that everything is okay. So we'll get the gas syringe done. Okay, well done,
Gas
team.
syringe here.
Okay, let's take the gas and send it off. Fantastic. Okay, so team, are we happy? Are we safe?
I'm just going to do an ATE assessment.
Assessment complete?
Yeah.
Okay, and the scenario is complete. Thank you.
Good morning po. For your attendance po, pasend po ng names, training course, and email po. Thank you po.
The Advanced Cardiovascular Life Support, or ACLS, is a series of evidence-based responses simple enough to be committed to memory and recalled under moments of stress. These ACLS protocols have been developed through research, patient case studies, clinical studies, and opinions of experts in the field. The gold standard in the United States and other countries in the course curriculum published by the International Liaison Committee on Resuscitation, or ILCOR. Previously, the ILCOR released periodic updates to their cardiopulmonary resuscitation, or CPR, and emergency cardiovascular care, or ECC, guidelines on a 5-year scale, with the most recent update published in 2015. Moving forward, the ILCOR will no longer wait 5 years between updates. Instead, it will maintain the most up-to-date recommendations online at eccguidelines.heart.org. Healthcare providers are recommended to supplement the materials presented in this video series and the corresponding manuals with the guidelines published by the ILCOR and refer to the most current interventions and rationales throughout their study of ACLS. While ACLS providers should always be mindful of timeliness, it is important to provide the intervention that most appropriately fits the needs of the individual. Proper utilization of ACLS requires rapid and accurate assessment of the individual's condition. This not only applies to the provider's initial assessment of an individual in distress, but also to the reassessment throughout the course of treatment with ACLS. ACLS protocols assume that the provider may not have all of the information needed from the individual or all of the resources needed to properly use ACLS in all cases. For example, if a provider is utilizing ACLS on the side of the road, they will not have access to sophisticated devices to measure breathing or arterial blood pressure. Nevertheless, in such situations, ACLS providers have the framework to provide the best possible care in the given circumstances. ACLS algorithms are based on past performances and result in similar life-threatening cases and are intended to achieve the best possible outcome for the individual during emergencies. The foundation of all algorithms involves the systematic approach of the BLS survey and the ACLS survey using steps A, B, C, D that you will find later in this video series. Please refer to the Basic Life Support Provider Handbook and corresponding videos, also presented by the Save a Life Initiative, for a more comprehensive review of the BLS survey. This video series and its corresponding manual specifically covers ACLS algorithms and only briefly describes BLS. All ACLS providers are presumed capable of performing BLS correctly. This concludes Introduction to ACLS. Next, we'll review ACLS Initial Assessment. Welcome to the lesson on ACLS Initial Assessment. In this video, we'll discuss determining the consciousness and unconsciousness of an individual. Determining whether an individual is conscious or unconscious can be done very quickly. If you notice someone in distress, lying down in a public place, or possibly injured, call out to them. Make sure the scene is safe before approaching the individual and conducting the BLS or ACLS survey. When encountering an individual who is down, the first assessment to make is whether they are conscious or unconscious. If the individual is unconscious, then start with the BLS survey and move on to the ACLS survey. If they are conscious, then start with the ACLS survey. This concludes our lesson on ACLS Initial Assessment. Next, we will review Basic Life Support. Welcome to the overview on Basic Life Support. In this video, we'll briefly discuss the general concepts of Basic Life Support. The ILCOR has updated the Basic Life Support, or BLS, course over the years as new research in cardiac care has become available. Cardiac arrest continues to be a leading cause of death in the United States. BLS guidelines have changed dramatically, and the elements of BLS continue to be some of the most important steps in initial treatment. General concepts of BLS include the chain of survival, high-quality chest compressions for adults, children, and infants, AED use, rescue breathing, teamwork, and treating choking. For adult BLS algorithms, please refer to Figures 3 and 7 in your corresponding manual. This concludes our overview on Basic Life Support. Next, we will review Initiating the Chain of Survival. Welcome to the lesson on Initiating the Chain of Survival. In this video, we'll learn about the BLS adult and pediatric chains of survival. Early initiation of BLS has been shown to increase the probability of survival for an individual dealing with cardiac arrest. To increase the odds of surviving cardiac event, you should follow the steps in the adult chain of survival. The first step in the adult chain of survival is to recognize symptoms and activate EMS. Next, perform early CPR. Then, defibrillate with AED. Once the EMS team arrives, they will provide advanced life support to the individual. When the individual becomes stable and is taken to the hospital, they will receive post-cardiac arrest care. Now, let's review the pediatric chain of survival. Emergencies in children and infants are not usually caused by the heart. Children and infants most often have breathing problems that trigger cardiac arrest. The first and most important step of the pediatric chain of survival is prevention. This means if you come across a child or infant who is experiencing breathing problems, take immediate action. In the case that the heart does stop, activate EMS and perform high-quality CPR. If they are still unresponsive after performing CPR, the EMS team will perform advanced life support. After they are stable and taken to the hospital, they will receive post-cardiac arrest care. This concludes our lesson on initiating the chain of survival. Next, we'll review 2020 BLS guideline changes. Welcome to the lesson on 2020 BLS guideline changes. In this video, we'll discuss the 2020 CPR guideline changes. The importance of early initiation of CPR by lay rescuers has been re-emphasized. The risk of harm to the patient is low if the patient is not in cardiac arrest. Bystanders should not be afraid to start CPR even if they are not sure whether the victim is breathing or in cardiac arrest. A sixth link, recovery, was added to the chains of survival for both pediatric and adults. Care of the patient after the return of spontaneous circulation, or ROSC, requires close attention to oxygenation, blood pressure control, evaluation for percutaneous coronary intervention, targeted temperature management, and multimodal neuroprognostication. Because recovery from cardiac arrest continues long after the initial hospitalization, patients should have formal assessment and support for their physical, cognitive, and psychosocial needs. After a resuscitation, debriefing for lay rescuers, EMS providers, and hospital-based healthcare workers may be beneficial to support their mental health and well-being. Management of cardiac arrest in pregnancy focuses on maternal resuscitation with preparation for early perimortem cesarean delivery if necessary to save the infant and improve the chances of successful resuscitation of the mother. This concludes our lesson on the 2020 BLS guideline changes. Next, we'll review one rescue.
Hi, let's resume na po. Pa-on muna ng mga videos nila para ma-check po natin kung nandyan pa ba ang mga students natin. Nag-breakfast na ba? Nairaos pa ang kagutuman? Kaka-coke lang ni Ma'am Janice ka. Ako, kahit ako diabetic ako, ma'am, nagko-coke pa rin. Chas. Coke is lifeless kaya. Diba? Mawala na lahat, wag lang ang soft drinks.
Pampagising lang po, sir.
Yes, masarap talaga ang Coke na pampagising, na pampa-energize. Like sobrang the best talaga yan. Kahit ako din, kahit ako. Kasi minsan ang coffee ay ineffective na sa akin eh. Parang wala na siyang effect. Sige po. So we're done na po sa ating mga pre-arrest setting, 'di ba? Tapos na po tayo sa sinus bradycardia, tapos na po tayo sa SVT natin, at tapos na po tayo sa ventricular tachycardia with pulse. Now, let's enter na po what we call as the arrest setting. On the arrest setting po, guys, syempre, na on cardiac arrest na ang patient natin. So malamang hindi na po siya conscious, meaning to say unconscious na ang patient mo. So this is the time po nagigisingin na po natin ang patient. Guys, paano ba gumising ng patient po? Let's say performing BLS in an intra-hospital setting. Syempre, hindi ka na mag-check ng scene safety like yung mga looking for up and down, para kang tanga sa ER. 'Di ba? Iba kasi ang intra-hospital na sa pre-hospital setting. Pag pre-hospital po, doon ka mag-check ng hazards, 'di ba? Check for safety, looking up and down, tapos sisigaw ka ng help, no? Pag outside hospital. Pero pag inside the hospital na po, ganito ang gagawin po natin. Tawagin mo siya sa pangalan. Mrs. Fernandez, are you okay? Mrs. Fernandez, are you all right? Mrs. Fernandez is unresponsive. Code blue to ER bed 1, please. Code blue to ER bed 1. Checking for pulse and breathing. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000. Mrs. Fernandez has no pulse and is not breathing. I'm going to start with my high-quality chest compression. Ganun po na ang inside the hospital setting. Okay? Ayan, sige. Now, if nag-arrest na po ang patient po natin, guys, you perform the BLS survey. No, you perform the BLS survey. Now, on the arrest setting kasi, I'll give yung mga scenarios po natin. So, let's treat the patient. Okay, let's say, what if nag-VFib si patient or what if nag-VTAC ang patient mo, negative pulse. Ano kaya ang gagawin po natin? Guys, everybody say VFib.
VFib.
Ayan, great. No? And then we have here the VTAC, okay, with negative pulse. Meaning, okay, nag-arrest nga ang patient natin. Unconscious ba ang patient natin dito? Yes, pag unconscious ang patient, guys, no need for you to check the patient's BP kasi wala naman talagang BP ang patient. Wala ngang pulso eh. So we have here the class 1. So anong gagawin po natin? Pag class 1, it's high quality CPR or high quality chest compression. Class 2A and then class 2B. Pag class 2A po natin, of course, we need to defibrillate the patient. Charging 2, pwedeng 100 joules, pwedeng 150 joules, at saka pwedeng 200 joules. Depende sa iyo yan. May mga doctors po na maximum na agad na 200 joules. Bakit 200 joules, sir? Kasi we are following the biphasic kasi eh. Biphasic kasi yung protocol po natin. Ito yung pinaka-updated na po. Hindi na yung mga 360, no? 200 na po ngayon kasi both paddles will give okay, electrical charges kasi. So aside from your class 2A, we have the class 2B. Guys, this time, no meds po tayo. Alam niyo ba kung bakit no medications tayo? Kasi baka ma-okay ang patient nyo upon shocking the patient. Ulitin ko lang ha. We have our class 1, class 2A, and then we have the class 2B. Bakit no med, sir? Kasi itong dalawang to, your VFib and your VTAC negative pulse, they are shockable. Tama ba? Pag shockable, baka ma-okay sila sa first shock po natin. However, kasi sinabi ng doktor, 2 minutes up. Pag 2 minutes up po, sasabihin ng team leader nyo, let's stop the compression, let's analyze the rhythm on screen, and let's switch roles. Alam niyo ba, pag 2 minutes po, automatic si team leader, guys, napanood niyo ba yung movie ni Angel Locsin at saka si Vilma Santos, yung nangyari sa ICU? Sabi 'di ba sabi ni Angel Locsin doon, VFib on screen. Let's start high quality chest compression now. Okay, let's defibrillate the patient charging to 200 joules. There should be no medications. Okay, 2 minutes up. Let's stop the compression. Let's analyze the rhythm and let's switch roles. Yun yung sabi ni ni Angel Locsin. Now, stop the compression. Why? Because we are going to analyze the rhythm on screen para hindi po ma-alter ang tinatawag na rhythm sa screen po natin, and then we switch roles. Ang nagsiswitch po ng roles will be the compressor. Ayan. And then the defibrillator din po natin. Kung sino yung magko-compress at saka kung sino yung magde-defib, sila lang dapat ang na mag-switch ng roles po. Standby na po ang ventilator po natin. Alam niyo ba kung bakit? Kasi yung ventilator po natin, most likely mga doctors kasi yan, na pag mega code. Kaya pag sinabi po ng tinatawag na doktor, yung pinaka-head or pinaka-team leader po natin, sasabihin niya, okay, Doc Gonzalez, ayan, please, okay, intubate the patient now. Kaya standby always ang mga ventilators po. Wait lang ha, baka may mga nag-message or baka may mga nag-chat. Ayan, mag-send na po kayo ng complete name nyo. Tapos your your email address din para ma-send po namin yung mga emails, yung mga certificates and cards po natin. Now, aside from your class 1, okay, class 2, ayan, sir, after 2 minutes po, biglang bumalik si VFib. Tapos biglang bumalik din si VTAC, okay, negative pulse. Either si VFib ang bumalik, or si, ayan, VTAC, okay, negative pulse. Ayan, anong gagawin po natin, sir? The same pa rin po, guys. We have the class 1, we have class 2A, and then we have class 2B. Guys, ano kaya ang class 1 natin? Ibalik mo pa rin nasa high quality chest compression. Perform high quality chest compression. You defibrillate the patient now. And then this time, guys, you're going to give your medications. Ano kaya yung drug of choice po natin dito? Walang ibang sagot, we have the epinephrine. It's epinephrine 1 milligram. 1 is to 10,000 dilution. You flush it with 20 cc. Ayan, plus 20 cc of plain NSS. And then, okay, you elevate arms. Ayan, elevate arms of the patient for about 10 to 20 seconds po. Sulat. So we have the drug of choice, which is the epinephrine 1 milligram, 1 is to 10,000 dilution. You flush it with 20 cc of plain NSS and arms elevated for about 10 to 20 seconds. Again, this is the drug of choice po. Ayan, an emergency drug. Na? So again, wala po tayong maximum dose for epinephrine, ethically. However, may mga protocols pang hospital na 3 doses lang ang kaya nilang maibigay. May iba din, pinaka-max po 7, yung iba pinaka-max like 8. Meron akong ex dati, char. Bigay talaga siya ng 12. And then luckily, na like miraculously din, for me it's a miracle na eh. Nag-12 na tapos biglang nabuhay ang patient. As in like amazing yan. Sobra akong namangha sa kanya. Ayan. So wag pong ipagdamot ang epinephrine. Iba po ang kaligayahan pag nabuhay po yung nire-resuscitate po natin. Now, after epinephrine, again guys, alam niyo ba ang epinephrine? They should be given every 3 to 5 minutes. Ayan, every 3 to 5 minutes po. So meaning to say, pag sinabi ko na naman ulit, 2 minutes up. Ayan, 2 minutes. Ayan, up. Anong sasabihin natin? SAS. Let's stop the compression. Let's analyze the rhythm on screen. And let's switch, roles. That's after 2 minutes. Now, what if bumalik na naman ulit? Sir, si VFib na naman. Or ventricular tachycardia, negative pulse. So, anong gagawin natin? Guys, kayo nang sasagot nito. Pag sinabi kong class 1, anong isasagot natin?
High quality.
Class 1.
High quality.
High quality chest.
Na it's high quality CPR. Meaning to say, sir, mali pala yung sabi nila na pag VFib sounds like defib agad. Yes. Kasi ganito yan. It takes time kasi para mag-prepare po ng defibrillating machine natin or the defibrillator. So since, nagpre-prepare ka pa, why not mag-start ka na ng immediate high quality chest compression? And if ever kung ready ng defibrillator mo, doon ka na magpapa-defibrillate. Pero wag niyong patapusin ang 5 cycles, tas doon ka pa magpapa-defibrillate. No. In the middle po, at pag ready na ang tinatawag na defibrillator mo, sige, i-defibrillate mo na kasi ang pinakamagandang combination kasi ngayon guys, rapid, or let's say early CPR plus early defibrillation, lalo na pag shockable ang rhythm po ng patient, then maganda po ang survivability, ang prognosis ng patient mo. Pag kinombine mo ang dalawa. Kasi pag early CPR lang without an early defibrillation, pangit din. Na? The cases of, let's say VFib, diba? VTAC, negative pulse, ayun po. Now, ayan. So aside from having your class 1, we have the class, 2A. With your class 2A po, we need to defibrillate, the patient. And then we have the class 2B. For the class 2B, iba na naman po yung drug of choice po natin dito. Kanina kasi ang drug of choice po natin, epinephrine. Hindi kasi pwedeng magkakasunod-sunod ang epinephrine natin. So it should be epiamiodarone. So ito yun. Drug of choice natin dito, sir, will be your amiodarone. What's the dose? Siyempre, 300 milligrams. You flush it with 20 cc of plain NSS. And then arms. Elevate. Arms po. Ayan. Elevate. Arms of the patient for about 10 to 20 seconds. Sir, question. Bakit? Bakit po amiodarone ang ibinigay? Take note guys, the action of your epinephrine, di ba, is for about 3 to 5 minutes kasi. Let's say kanina, nagbigay ka ng epi na. Dito nagbigay ka ng epi. Tapos sinabi ko, 2 minutes up lang. Meaning may 3 minutes ka pang gumagana pa ang tinatawag na epinephrine mo. And alam niyo ba, pag let's say continuous po ang pagbigay, or repeated intervals po, continuously nagbibigay ka ng epi, pwedeng siya din ang reason kung bakit bumalik ang tinatawag na ventricular fibrillation or ventricular tachycardia negative pulse. Meaning ang tawag doon, refractory, biglang bumalik. Pwede kasi brought about by epinephrine yan. There's a study na ganun po ang nangyayari. So, instead of giving epi, why not give epi tas amiodarone, epi tas amiodarone? Meron ding updates po based on the 2021 guidelines. Guys, aside from giving, now we have the second drug here. second drug na po. In the absence, of your amiodarone, ayan, you can give your lidocaine. Sulat ko lang ha. You can give, your lidocaine. Ayan, syempre yung lidocaine natin, meron tayong first dose, meron din tayong second dose. Meaning pala, sir, yung amiodarone mo, meron kang, first dose, which is your 300 milligram. Meron ka ring second, dose, which is half lang po, which is 150 milligrams. Nakuha? May first dose cut, may second dose. Sa second drug po natin, guys, which is your lidocaine, meron siyang first dose, meron din po siyang second dose. The first dose for your lidocaine will be, 1 to 1.5 milligram, per kilogram. The second dose will be the 0.5 to 0.75, milligram, per kilogram. Sir, and then you flush it pa rin. Flush it with 20 cc of plain NSS, and then you elevate the arms of the patient for about 10 to 20 seconds na naman po. So ulitin ko lang ha. Sorry, sinipon ako bigla. Naririnig ba yung sipon ko? Ayan, so we have your amiodarone. Nakaka-paranoid na sipon. Diyos ko. Ayan, so we have your amiodarone. That's for the first drug natin. Ayan, after epi. So epi tas amio. Either amio or lidocaine. Kasi in-insert na naman ng 2021 guidelines si lidocaine po. Although tinanong ko naman yung mga friends ko na mga doctors, Doc, gumagamit na ba kayo ng lidocaine ngayon? Kahit alam daw nila na may mga updates naman, kampante na daw sila sa sa amiodarone. Pero kung wala talagang amiodarone, edi magla-lidocaine sila. 'Di ba? Sikat din kasi si lidocaine as an antidysrhythmic drug Your amiodarone is an antidysrhythmic, na? Your lidocaine, na, is also an antidysrhythmic, kasama nila procainamide, na? So, we have the first and then we have the second dose. Nakuha po ba? So, meaning to say, guys, let's say nag-run tayo ng scenario na. Let's say nag-VFib si patient. Ano yung first drug natin? Wala pa, 'di ba? No, meds. Tapos biglang magme-med ka na dito. Let's say 2 minutes up. Okay, magbigay na tayo ng medicine. Epi, first dose. Ayan, after 2 minutes na naman, we have the amiodarone. Ayan, first dose. Tama po. Tapos right after na naman, we have the epi, second dose. Tapos we have the amio, ayan, second dose na naman. So on and so forth po. So pwede ka magbigay ng amio at pwede ka rin magbigay ng, ayan, yung lidocaine po natin. Nakuha po ba? Ayan guys, pa-heart react nga if clear po na ang mga meds po natin. Ayan, thank you so much. No, I'm seeing heart reactions po. Ayan, galaw-galaw din po tayo para hindi ma-stroke. Sabi nga nila, galaw-galaw daw para hindi pumanaw. Diyos ko Lord. Kakakain ko lang tapos ayan, lamang loob na naman ang kinain ko, guys. So malamang good luck na lang sa uric acid ko na naman later. Ang importante, may medication. 'Di ba? Yung mga pinaka-hard-headed din ng mga patients yung mga mga medical professionals. At tayo 'yon. 'Di ba? Ang dami ko ding mga barkada ng mga doktor, 'di ba? Ng mga nurses po na matitigas din talaga ang ulo, no? Kung maka-health teaching, parang perfect. Para pag sa sarili na nila, Diyos ko, mga talaga, mga pasaway din na. Now, aside from your, VFib and VTAC, guys, let's proceed sa another arrest na naman, and that's the asystole. And we have the PA, or the pulseless electrical activity. Ayan, do not forget yung protocols po natin for the asystole, and do not forget also the H's, and T's, ng tinatawag na PA po natin. Now, asystole, and PA on screen. If ever kung nakita po natin sila, guys, syempre wala po tayong ibang gagawin, but rather, sisigaw po tayo ng class 1. It's your high quality CPR. Class 2A, question, defib or no defib? Asystole and PA. Defib or no defib?
No defib.
Great po, ma'am. It should be no defibrillation. And then class 2B, guys, we have the medication here. We have the drug of choice, which is the epinephrine. The same pa rin po, 1 milligram, 1:10,000 dilution. Pag sinabi po nating 10,000, 1:10,000, meaning to say you're going to aspirate 1 ml of your epinephrine and then you aspirate also 9 ml of your plain NSS, making it 10 ml. And then yun yung first na ibibigay mo kay patient. Yung 1 ml of epi plus 9 ml of your plain NSS. That's your 1:10,000 dilution. Now, pagkabigay mo, i-flush mo naman siya ulit. Now, you flush it with 20 cc of plain NSS and then you elevate the arms. Why? By flow of gravity kasi, bababa po yan sa heart. And then si heart, no? Ayan, slowly papump niya yan towards the systemic circulation. Okay po ba? Ayan, now, aside from your no? Let's say guys, na pag 2 minutes up na naman, ayan, hindi again ha, puro epi-epi lang. Pwede ka namang mag-amio dito na with your asystole and with your PA. Pwede ka mag-amiodarone. The same pa rin ang pattern. Yung epi-amiodarone, or epi-lidocaine, and then epi-lidocaine. Okay po ba? Ayan. Sige. So, ayan. Now, we're done na. Okay, let's try to, apply them. Try nating i-apply. Pero before that, magpapa-quiz muna ako. Sige nga, kuha muna kayo guys ng clean sheet of paper. Kasi I'll be flashing po yung mga ECG po natin. And then try to identify them. Okay? Tapos picturean nyo lang, tapos isend nyo lang sa, let's say sa GC or sa group ba, or let's say sa FB Messenger po ng WePump. No? That will serve kasi as your attendance din. Picturean nyo lang yung parang quiz po. Kasi magpapa-quiz ako ngayon. Okay, clean sheet of paper po. Okay, let's begin. Again this will serve as your attendance din. So picturean nyo lang yung mga results nyo. Let's begin now. Okay, pa-on nga ng mga cameras nila, pa-show po ng mga sagot nila. Okay, the correct answer is atrial tachycardia or your SVT, the supraventricular tachycardia. I can see smiles on their faces. Huwag niyo lang isagot ang asystole. Ay, bongga, may pa-cellphone si Madam. Next po.
Bradycardia.
Okay, pasulat na lang po ng mga sagot nila. The correct answer is sinus bradycardia. Next. Okay, the correct, show me your answers po. Show me your answers. Ayan, okay. I'm seeing NSR, correct po. That's your normal sinus rhythm. Next.
Vita.
Okay, correct answer po is
Vita.
yeah, it's VTAC. It's monomorphic. Okay, VTAC. Next.
Assist.
Okay, guys. Correct answer is ventricular fibrillation. Okay. Pa-mute na lang muna ha, kasi may naririnig akong mga noises po. Sorry. Ayan. This is your ventricular fibrillation. Next po, guys. Isulat po ang tamang sagot.
Asystole.
Okay, so we have your asystole as for the correct answer. Next po. Okay, you show me your answers po. It's atrial flutter or the atrial flutter. Next, guys. Okay, answers po. It's atrial fibrillation. Next. Okay, I am seeing correct answers po. It's sinus,
Tachycardia.
ayan, sinus tachycardia. Great. Next po. So this one is what? Sinus arrhythmia. Okay, that's sinus arrhythmia po. Okay, please submit your answers na. Can I have a copy of your of your exams or quiz? And i-send po natin sa FB Messenger. Ayan, pa-mute na lang ha. Sige po. Pa-submit na lang sa Messenger ng WePump. WePump, can I be your host po? Pasan na lang ng host po, ma'am. Kasi para makamute din ako or whatsoever.
Sa Messenger po.
Yes, ma'am. If sa Facebook Messenger po. Sige. So let's recall again. Na? Magre-recap ulit tayo ha. Magre-recap lang tayo guys. So we have the pre-arrest. We have the arrest. And then we have the post-arrest setting. On the pre-arrest setting, naalala ba ang mnemonic natin na vomit? Now you visualize, verbalize, and vital signs. Okay, iraran ko ha. Meaning to say, gagamitin ko yung mnemonic ko na vomit. So ganito yan. Arriving at the emergency department is a 75-year-old female patient whose name is Mrs. Ricardo. Mrs. Ricardo is a cold, clammy, diaphoretic patient on ER bed 1. So tapos na tayo sa pag-visualize. You approach your patient now. So verbalization. Good morning, Mrs. Ricardo. I am Mark Adlawan, your most responsible nurse. How are you feeling today, Mrs. Ricardo? Mrs. Ricardo responded, I am so tired, Mr. Adlawan, and I feel like I'm dying. Oh, Mrs. Ricardo, you are so upset. But before that, let me check your vital signs first. With a heart rate of 175, a BP of 70/40, RR of 42, with an O2 sat of 91%. Mrs. Ricardo, since your O2 sat drops na below normal, let me hook you to a nasal cannula or let's say, yung non-rebreather mask po natin at 15 liters per minute because that's ideal. Now, attaching the patient to the cardiac monitor, inserting IV at left brachial vein, and it's now time to treat the patient. Now, analyzing a rhythm on the monitor po. Okay, analyzing ECG on screen. The heart rate is 38. The rhythm is regular. I can see P waves, they're clear and upright, followed by QRS, which is normal in nature. So therefore, the patient is suffering from sinus bradycardia.
Yeah.
Patient suffering from sinus bradycardia, guys, with a BP of less than 90/60. Is it stable or unstable? Stable or unstable?
Unstable.
It's unstable. So we're going to treat the patient now with the first drug of choice, which is for the atropine. Tama po ba? It's atropine at 0.5 milligram times 6 doses with a maximum dose of 3 milligrams given every 3 to 5 minutes. However kasi, if ever lang kung hindi let's say, umokay ang patient natin with atropine sulfate, then you proceed with transcutaneous spacing. Guys, paano nga ulit mag-transcutaneous space? Tingnan mo sa monitor. You check now or you press the pacer. Pag press mo sa pacer, dapat kasi meron tayong capture. Pag sinabi kong capture, QRS, QRS, QRS. Napansin niyo ba sa monitor niyo, QRS tapos flat, flat? QRS tas flat, flat. Dapat kasi QRS lahat ng makikita mo. Kasi ano nga ibig sabihin ng QRS, guys? QRS, okay, that only means na meron po tayong tinatawag na ventricular contraction. Tama po? So may ventricular contraction si patient. Now, itataas ko ang heart rate, guys, into 80 because the average heart rate is 80. And then, tignan mo, wala pa tayong capture. Pag sinabi kong capture, QRS, QRS, QRS. So ipapataas ko ang milliampere. 'Di ba sa ilalim ng 5, 'di ba, sa ilalim ng 80 may 5. Tataasan ko gawin kong 10. Tignan nyo kung may capture, wala pa rin. I-elevate ko up to 20, i-raise ko siya up to 20. Tignan nyo kung may capture, wala pa rin. I-raise ko pa up to 30, wala pa rin. Tignan nyo at 40 So napansin nyo, from 38 kanina, biglang naging 80. So tumaas nga ang heart rate ni patient. From 5 na milliampere kanina, yung ilalim ng 80, bigla kong ni-raise up to 40. So nagkakaroon lang po tayo ng capture pag 40 milliampere. Now sir, paano ko ba i-check kung ano talaga, kung nag-80 beats per minute na si patient? Simply, you need to make use of your stethoscope. Tama? Naalala ba si Litman, pang mayaman? Naalala? So yun po yung gagamitin natin. Pero kung walang Litman, ito yung mga ano ba yung box. Yung 'di ba? Yung mga depende sa brand na talaga na ayan. Basta ang pangmayaman, it's Litman para marinig ang labdab. Dapat din kung naglitman ka, dapat hindi pirata, dapat hindi peke, dapat hindi made in China. Kasi pag baka made in China, guys, baka Chowking ang maririnig po natin sa ating stethoscope. Okay? Ayan, sige. Now, aside from that, kunwari na treat mo na si patient. Tapos, biglang nagkaroon ng, pagbabago kay patient. From pre-arrest, we are now entering the arrest setting. Guys, situation, i-run natin ang code. The patient suddenly loses consciousness. Mrs. Ricardo becomes unresponsive. So what are we going to do now? You're going to perform the BLS survey. Gigisingin mo na si patient. Mrs. Ricardo, are you okay? Mrs. Ricardo, are you all right? Mrs. Ricardo is unresponsive. Code blue to ER bed 1, please. Code blue to ER bed 1. Checking for pulse, checking for breathing. 1,000, 2,000, 3,000, 3, 1,000, 4, 1,000, 5, 1,000. Mrs. Ricardo is unresponsive or has no pulse and is not breathing. So we're going to start now with your high quality chest compression na po. Sabihin ko, okay, 2 minutes up. Let's stop, let's analyze, and let's switch roles. Tignan nyo guys. Ano ang nangyari kay patient? What's that? What's that? That's your ventricular, ventricular fibrillation. Okay? So no need na nasabihin na pulseless kasi pag sinabi nating defib, it's already pulseless po. So this is your ventricular fibrillation. Ayan. If that's your ventricular fibrillation, guys, class 1. Class 1 is what?
High quality.
Great. No? Guys, i-click ko rather yung CPR, meaning nagko-compress ako. Guys, what's class 2A? Defib or no defib?
Defib.
Okay, defib. Lower down muna your volume kasi medyo maingay to. So what if inutusan ako ni Doc? Mr. Adlawan, please defibrillate the patient now, charging to 150 joules. Okay, Doc? Charging to 150 joules. Please clear the patient. Paddles on chest. 1, I'm clear. 2, you're clear. 3, everybody's clear. Clear. Shocking, shocks delivered. So guys, anong sinabi ko doon? Ayan, charging the patient to 150 joules, you press charge. Please clear the patient, paddles on chest. 1, I'm clear. 2, you're clear. 3, everybody's clear. Clear. Shocking, shocks delivered. Resume high quality chest compression. Press. Now, I have a question. Drugs or no drugs? Meds or no meds? Guys, meds or no meds? No meds first, tama? Yeah, no meds muna. On the first run, hindi muna tayo magbibigay ng medication. Pero on the second run, magbibigay na po tayo ng medication. Ano nga yung medication natin? Anyone? Epi. No, epi muna. Di ba epi muna? Tama nga? Yeah, epi muna. So epinephrine, 1 milligram. 1 is to 10,000 dilution. You flush it with 20 cc of plain NSS and arms elevated for about 10 to 20 seconds. And then after epi, guys, will be your amiodarone first dose. After first dose ng amio, will be the second dose of epi. Tama po? After second dose ng epi will be the second dose of your amio or the second dose of your lidocaine. Question, what's the first dose for amiodarone? 300 milligrams na. Next, how about for the second dose? Syempre yung half. Tama po? Do not forget that hindi dapat puro first dose lang. Dapat may second dose din po tayo. Pero kasi ba? Ayan, sige. So kunwari lang. Kunwari na okay na po si patient. Biglang nagkaroon ng return of spontaneous circulation. So let's proceed na sa ating post-cardiac arrest care. Now, the post-cardiac arrest care, guys, kanina kasi diba pre, tas may arrest, tas may post-arrest. You're going to check for the return of spontaneous circulation by checking for the pulse rate, checking for the RR or the breathing, and then checking for the PETCO value or the PET CO2. Now, aside from that, you're going to check also the airway breathing, the circulation of the patient. Next, we have the disability, and then we have the sign of the cross. Sir, bakit may sign of the cross? Buhay or patay ang patient natin? Buhay or patay si patient, guys? Anyone? Siyempre, buhay po ang patient natin, kaya may sign of the cross tayo. Thank you, Lord, dahil buhay ang patient. Dahil competent ka na nurse eh. Hindi ka anga-anga na nurse. Ayan. And syempre from Bicol ka eh. So malamang magaling ka talaga. Uragon. Tama? Pag babae din ba, uragon or uwagon? Chos. Pag babae, anong tawag sa babae? May uragon din ba na babae? Meron din. Meron din. So pwede din gamitin yung term na uragon. Okay. Ayan. So we have the airway, breathing, circulation, then we have the disability. Guys, pag-check nyo, kasi nabuhay bigla ang patient, may pulso na po ang patient natin. So you check for the airway and breathing. What if the patient has pulse rate, but the patient is not breathing? Anong gagawin natin? Rescue breaths. Magbibigay ka ng rescue breaths. However, what if biglang nag-drop ang O2 sat to 84% or ang GCS niya guys is less than 8? This is the time na we need to have your intubation. Kailangan magpapa-intubate na po pag less than 84% ang kanyang O2 sat at pag ang GCS niya is less than 8. Proceed with intubation. However, nurses are not allowed to intubate, no, only our lovely physicians. Next, we have the circulation. I am referring to the BP of the patient because the BP of the patient is so low, so we have a hypotensive patient. Guys, di ba pag hypotensive ang patient niya, pataasin niyo ang BP ng patient. Ano ba usually ang sinasabi ng mga doctors po natin sa hospital? Sasabihin niya, or let's say siya mismo ay mag-auscultate. Now, checking for, breath sounds. Check, breath. Ayan, breath sounds. Or lung sounds po. Pag-check mo ng breath sounds and lung sounds, or lung sounds, what if, sir, negative crackles or negative ralls si patient? Alam niyo ba guys na your ralls or your crackles, they signify what? Na a fluid-filled lung. Meaning to say, may pulmonary congestion po na nangyayari inside. Pero since negative naman siya, pag negative po, we have the management known as the 1 to 2 liters IV, bolus of your plain, NSS. Okay po? You run it fast drip. Ulitin ko lang ha. If there's no crackles or ralls, meaning no signs of pulmonary congestion, you run 1 to 2 liters of IV bolus of your plain NSS. Pero what if merong crackles? Nge. What if may ralls? Nge ulit. So we have the management. If ever kung may mga signs of pulmonary congestion ka, you are not allowed to give IV bolus as ordered. Na instead of giving, yung mga bolus po natin na mga hydration po natin known as the fluid resuscitation, why not give, this drug of choices po? Now, my mnemonic will be the mnemonic then. Why? DOPA, epi, and norepinephrine. Now, what are the doses? Guys, if you can vividly recall, based on my discussion po, what's the dose ulit of your dopamine vasopressor dose? Anyone from the group? It's at what? At 10 microgram per kilogram per minute. Great, thank you po. Next, for the epi and norepi, the same sila, 2 to 10, microgram, per minute po. Ulitin ko lang ha. Dopamine, 10 microgram per kilogram per minute. For the epi and norepinephrine po, it's at 2 to 10 microgram per minute. Again, I'm just channeling kung ano yung mga binigay ng American Heart Association. I'm not trying to guluhin yung mga let's say protocol niya sa hospital. Kasi ang masusunod naman din talaga sa hospital po natin is syempre yung mga doctors po natin. 'Di ba? Yung mga chief of hospital po natin, sila dapat ang masusunod. Na ayan, nirelay ko lang din kung ano yung kailangan daw naming i-discuss, 'di ba? Para sa para maging updated naman po tayo. If ever kung ito ang ginagamit ng hospital nyo, sige, i-updated po yung hospital po natin. Now, what's next nga to your letter C? It will be your letter D. Tama ba? And I am referring to disability. Madi-disable ba ang client? Siyempre hindi, no? For the disability kasi guys, may tatanungin ka kay patient. Na ano ba yung tatanong mo kay patient? You're going to check kasi the GCS or the Glasgow Coma Scale of your patient. No? It's a form of neurovital sign. Okay, checking kasi. So, ano ang gagawin mo? For the disability guys, lapitan mo si patient. Mrs. Ricardo, can you squeeze my hand? Ay, no response. Guys, pag no response po, GCS3 na automatic yan. Na pag nasa ER. Pag no response, GCS3. Na pero pag may response, tas sinampal ka bigla, ay GCS15. Sobra pa sa 15. Tama? So pag sinampal ka ng patient, anong gagawin mo? Slowly, you slap that bitch back also. Chos. Magpapalugi ka pa ba? Konti na nga lang yung sahod natin, tapos sasampalin ka pa. Sampalin mo rin, di ba? And so we have the no response. Napapalakpak pa si Mambuba, no? Pero syempre, sampalin mo lang pag walang CCTV. Pero pag may CCTV, wag na lang, baka maano pa tayo. Baka machismis pa tayo. Alam niyo ba pinaka-worst na narinig ko talaga at na-witness ko din? Dito sa Davao guys, meron kasing government hospital na sobrang laki. By the name of SPMC. Pinakamalaking hospital, government hospital yan. May helipad pa yan eh. Sobrang social lang. Na funded yan ng Japan, ng China, ng Germany. Ang daming nag-fund dyan. Kaya ang daming buildings niyan. Alam ko kasi ito na yung pinakamalaking hospital. Tinalo niya na ang UPPGH. Kaya wala nang sinabi ang UPPGH no, with SPMC sa Davao. Like, ang daming buildings, ang lalaki lang. Pero ang pinaka-worst na narinig ko, nag-aspirate na kasi mag-venipuncture si Medtech. Alam mo ba na mataas na pala ang kreya ng patient? Biglang kinuha niya ang syringe, tapos pinagsasaksak niya ng syringe ang nurses, ang doctor sa ER. Guys, can you imagine, syringe, isasaksak sa'yo? Diyos ko, pinaka-worst yun. Na? Kaya sabi ko, kung gusto mo talagang pumayat at gusto mong ma-challenge, no, go to that hospital. Pag ER nurse ka doon, there's no time for you to sit. Na wala talagang oras para umupo. Always kang nakatayo at hindi ka nakakain. Parang gusto kong mag-duty doon para papayat din ako. Kaso nga lang ang problema pag diabetic ang hypoglycemia because that leads to irreversible brain damage at ayaw po nating mabrenda. Okay na sigurong tumaas ang sugar, wag lang mabrenda. 'Di ba pinakakalaban niya ng diabetic ang ma-hypogly. Okay lang ma-hyper, at least happy, party. Pero pag hypo, Diyos ko po, halos hindi ka na makasigaw, 'di ba? Tas comatose ka bigla. Nakakatakot, Diyos ko. So we have the disability. Guys, in case lang na GCS3 po ang patient natin, meron kasi tayong update na bakit may SVT? Ngayon lang ata na-send yung SVT mo, ma'am. sa group chat may nag-chat ng SVT. Ma'am, palitan niyo na po yung Oh, eto pa, may sinus bradycardia pa. Miss Bilon. Kanina pa po yung yung ECG po natin. Ngayon lang nag-send. Aray ko, pili ko madami pa siyang isi-send ngayon. Ang importante tama si ma'am, SVT talaga 'yun eh, no? Tapos yes, tama ka din ma'am, may sinus bradycardia din po kanina na ayan. Tas ang ano ko lang ma'am, mapayo ko lang, palitan mo na po yung internet connection niyo. Kasi parang 1 hour na po ang nakalipas. Joke lang. Ayan, if ever guys, na kung GCS3 po si patient, meron tayong tinatawag na TTM. Your TTM stands for Targeted Temperature Management. Your targeted temperature management, guys, this decreases oxygen demand, okay, from the brain. So pag nag-decrease po tayo ng oxygen demand, okay, from the brain of the patient, it prevents, okay, the occurrence of stroke. From the word itself, targeted temperature management, you're going to cool down the temperature, bring down the temperature for about 30 to 36 degrees Celsius for at least 24 hours. Okay po? Using a cold saline at 4 degrees Celsius, meaning malamig nga. Totoo nga ang sabi nila, pag mainit ang ulo mo, para hindi ka ma-stroke, palamigin mo ang ulo ng isang tao. So meaning, palalamigin po natin si patient. This will kasi, 'di ba? This will preserve din yung brain natin para hindi talaga siya ma-stress. Kasi nga this decreases oxygen demand from the brain, maintaining a core body temperature of 30 to 36 degrees Celsius for at least 24 hours using a cold saline, guys, at 4 degrees Celsius. Okay po ba? Although may video naman tayo nito later. Ayan, sige po. Guys, focus na po tayo sa sign of the cross. Now, with your sign of the cross, before mo kasi siya i-refer sa tinatawag na intensivist or sa mga taga-ICU, naalala ko tuloy pag ER, kalaban ka ng lahat. Pag ER nurse ka, kalaban ka ng lahat. Why? Ewan ko ba? But ang toxic lang talaga. Yung tipong nagagalit yung mga from ward, 'di ba? Nagagalit yung mga taga-ICU. Galit sila, kalaban ng lahat ang ER. Guys, just so you know, ano ba ang gagawin ng mga ER? Alam nga naman ko kolektahin lahat nila ang patient, 'di ba? Tas andun lang lahat sa ER, Syempre, malamang i-distribute talaga yan nila, Yung iba kasi ayaw din talaga nilang mag-receive ng patients Yung tipong pagdalawa ang patients nila, feeling nila toxic na sila. Hoy, Diyos ko, ito nga 1:50, 1:60, or sabihin mo ng 1:to whole hospital. Naalala ko tuloy, di ba? May mga hospitals kasi na kung sino yung ER nurse, hala, magulat ka, siya pa yung naghatid sa'yo sa OB. Then siya din pala yung magpapaanak sa'yo. Grabe. Lahat na lang. Tapos nurse/security guard na din siya. 'Di ba? So madami-dami nga. Kinabahan ako. Akala ko nagpanty lang si Miss Janishka. Tapos biglang napatayo. Diyos ko, mag-ingat po kayo habang tumatayo. Malay ko bang nakapanty lang. So guys, let's have the sign of the cross. Magsa-sign of the cross tayo. Akala ko nakapanty lang si ma'am. So guys, ganito. Sa taas po, we have the NGT. Next, we have the Foley catheter, FC. Next, we have the 12-lead ECG. Next, we have the portable X-ray. And then we have the central line. The central line, access po. I'll explain one by one. We need to have NGT. Why? Diba for the purpose of lavage, naalala? If you want to lavage, meaning to say you want to lavas or irrigate, ipapalabas mo, lavage. If you want to give, then that's your gavage. Meaning to say to maintain nutrition of your patient, that's your gavage. And then at the same time, this is for the administration of medications po natin. Okay po? That's the purpose of your NGT. Your Foley catheter, guys, di ba anong sabi natin? We need to continuously monitor for the output of the patient. Why? A good cardiac output must have a good renal output also. Kaya you always have your Foley cath. Next. 12-lead ECG is for you to have a complete picture of the heart of the patient. For complete picture yan, that's your 12-lead ECG. Lastly, not lastly, but rather second to the last is your X-ray. Now, this is my question. Why do I need to have my portable X-ray? Anyone from the group? Sige nga. let's entertain, okay, let's entertain answers po. There are no wrong answers here. Now, there's always a room for improvement, guys. Diba? Ano kaya ang purpose, guys? What's the rationale? It's not rationale ha. Hindi po yan rationale, but rather rational. Again, sabay-sabay tayo. Everybody say rational.
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 Great. Yes, may nakita na ako for the correct placement. Check. Correct placement ng ating NGT, and at the same time, correct placement ng ating endotracheal tube. Congratulations, ma'am. Meron pang isa. Meron pang isa, guys. Great, na Ma'am Rothesa. Ayan, this is to what? Na to rule out rib fracture. Kasi kanina pa tayo, guys, nagko-compress. From rib fracture kasi baka ang patient po natin magkaroon ng tension pneumothorax, another complication. So that is why we need to, okay, what? Now have your portable x-ray to what? No, to check for mga what? No, to check for placement and to rule out for rib fracture. Next, we have here the central line axis. Your central line axis kasi would like to check for what? No, for the hydration status ng patient natin. Lalo na, di ba, for the central venous pressure monitoring, yung CVP po natin. Central venous pressure monitoring, now would like to what? Measure the volume or the hydration status ni patient. Whether hypervolemic ba si patient or hypovolemic ang patient natin. Lastly, you refer the patient to an intensivist. Okay? I-refer mo na siya sa intensivist. Pag sinabi kong intensivist, ito yung mga tao na nasa loob ng ICU. Yung mga ICU nurses, ICU tech po natin. Okay? So refer them to the intensivist. Before mo sila i-refer, magsa-sign of the cross ka muna. NGT, Folicath, 12-lead ECG. We have the portable x-ray and then we have the central line axis to measure for the hydration status. Okay po ba? Sige, let's have muna the question and answer portion. Q&A muna tayo, guys. Q&A. If wala, I'm going to run down na ha. Kung ano yung mga topics natin kahapon at saka ngayon via a video po. So volume up na tayo, guys. Magra-rundown na po tayo. This is the summary of everything na na-discussed din.
Lesson on 2020 BLS guideline changes. In this video, we'll discuss the 2020 CPR guideline changes. The importance of early initiation of CPR by lay rescuers has been re-emphasized. The risk of harm to the patient is low if the patient is not in cardiac arrest. Bystanders should not be afraid to start CPR even if they are not sure whether the victim is breathing or in cardiac arrest. A sixth link, recovery, was added to the chains of survival for both pediatric and adults. Care of the patient after the return of spontaneous circulation, or ROSC, requires close attention to oxygenation, blood pressure control, evaluation for percutaneous coronary intervention, targeted temperature management, and multimodal neuroprognostication. Because recovery from cardiac arrest continues long after the initial hospitalization, patients should have formal assessment and support for their physical, cognitive, and psychosocial needs. After a resuscitation, debriefing for lay rescuers, EMS providers, and hospital-based healthcare workers may be beneficial to support their mental health and well-being. Management of cardiac arrest in pregnancy focuses on maternal resuscitation with preparation for early perimortem cesarean delivery if necessary to save the infant and improve the chances of successful resuscitation of the mother. This concludes our lesson on the 2020 BLS guideline changes. Next, we'll review One Rescuer BLS and CPR for adults. Welcome to the One Rescuer BLS CPR for adults. In this video, we will discuss the One Rescuer BLS process and CPR steps. The general adult BLS process is to ensure safety of the scene, assess the injured or ill individual, activate EMS, perform CPR, and defibrillate. Now, let's review the CPR steps. Start CPR by checking for the carotid pulse on the side of the neck. Feel for the pulse for no more than 10 seconds. If you are not sure that you feel a pulse, then begin CPR with a cycle of 30 chest compressions and 2 breaths. Next, place the heel of one hand on the lower half of the sternum in the middle of the chest. Then, put your other hand on top of the first hand. Then, straighten your arms and press straight down. Compressions should be 2 to 2.4 inches or 5 to 6 centimeters into the person's chest and at a rate of 100 to 120 compressions per minute. Make sure that between each compression, you completely stop pressing on the chest and allow the chest wall to return to its natural position. Leaning or resting on the chest between compressions can keep the heart from refilling in between each compression and make CPR less effective. Stop after 30 compressions. Open the airway by using the head tilt chin lift maneuver. Put your hand on their forehead and tilt their head back, then use your index and middle fingers on the lower jaw to lift up the jaw. Do not do the head tilt chin lift maneuver if you think that the individual may have a neck injury. In this case, use the jaw thrust maneuver. For the jaw thrust maneuver, grasp the angles of the lower jaw and lift it with both hands, one on each side, moving the jaw forward. If their lips are closed, open the lower lip using your thumb. Next, give a breath while watching their chest rise up. Repeat while giving the second breath. These breaths should be delivered for 1 second each. Resume chest compressions. This concludes our lesson on 1 rescuer BLS and CPR for adults. Next, we'll review 2 rescuer BLS and CPR for adults. Welcome to the 2 rescuer BLS and CPR for adults. In this video, we'll discuss the 2 rescuer BLS process and CPR steps. Many times, there will be a second person available who can act as a rescuer. The ILCOR emphasizes that cell phones are available everywhere now, and most have a built-in speakerphone. Direct the second rescuer to call 911 or your local EMS number without leaving the person while you begin CPR. This second rescuer can also find an AED while you stay with the individual. When the second rescuer returns, the CPR tasks can be shared. The steps for CPR are similar between 1 rescuer and 2 rescuer BLS. However, there are some slight differences. Let's review the 2 rescuer CPR steps. For the first step, have the second rescuer prepare the AED for use. Next, deliver chest compressions, counting out loud. Then, have the second rescuer apply the AED pads. Have the second rescuer open the individual's airway and give rescue breaths. Switch roles after every 5 cycles of compressions and breaths. 1 cycle consists of 30 compressions and 2 breaths for adults. Be sure that between each compression you completely stop pressing on the chest and allow the chest wall to return to its natural position. Leaning or resting on the chest between compressions can keep the heart from refilling in between each compression and make CPR less effective. Rescuers who become tired may tend to lean on the chest more during compressions. Switching roles helps rescuers perform high-quality compressions. Quickly switch between roles to minimize interruptions in delivering chest compressions. When the AED is connected, minimize interruptions of CPR by switching rescuers while the AED analyzes the heart rhythm. If a shock is indicated, minimize interruptions in CPR. Resume CPR as soon as possible with chest compressions. This concludes our lesson on 2 rescuer BLS and CPR for adults. Next, we'll review adult mouth-to-mask ventilation. Welcome to the adult mouth-to-mask ventilation. In this video, we'll discuss the use of a mask to deliver breaths in 1 rescuer CPR. Breaths should be supplied using a pocket mask. Chin lift maneuver, unless you suspect that the individual may have a spine injury. Press firmly around the edges of the mask and ventilate by delivering a breath for over 1 second as you watch the individual's chest rise. This concludes our lesson on adult mouth-to-mask ventilation. Next, we'll review adult bag mask ventilation. Welcome to the adult bag mask ventilation. In this video, we'll discuss the use of a bag mask to deliver breaths in 2 rescuer CPR. If 2 providers or rescuers are present and a bag mask device is available, the second rescuer is positioned at the individual's head while the other rescuer performs high-quality chest compressions. Begin by delivering 30 high-quality chest compressions, counting them out loud. The second rescuer holds the bag mask with 1 hand, using the thumb and index finger in the shape of a C on 1 side of the mask. This forms a seal between the mask and the individual's face. Using the other hand, the second rescuer opens the airway by lifting the individual's lower jaw. Finally, the second rescuer gives 2 breaths for 1 second each. Practice using the bag valve mask. It is essential to forming a tight seal and delivering effective breaths. This concludes our lesson on adult bag mask ventilation in 2 rescuer CPR. Next, we'll review normal heart anatomy.
Hello. Now I'm going to talk about one of my favorite topics, which is basic life support for cardiac arrest. So let's start off with a case scenario. We have a 58-year-old man. He's running along in a sporting event, and he suddenly drops, becoming pulseless and apneic. What do you want to do to save his life? We're going to talk about the most important interventions that you can perform right there on the scene that are most likely to improve his outcome. We're going to talk about why this happened physiologically, what might be going on with him, and we're going to talk about the supporting evidence that helps us know what the most effective interventions are. So what is cardiac arrest? The term cardiac arrest refers to the abrupt cessation of effective circulation. Basically, it means the heart is stopped. It encompasses a lot of different underlying diseases and conditions, but the final common pathway in each case is that the heart is not producing the effective circulation of blood to the body. So the primary cause of cardiac arrest, first and foremost, is coronary ischemia. The whole world over, that is the #1 cause. But there are other things that can lead to cardiac arrest as well, including cardiomyopathies, structural heart lesions such as valvular disease, electrical conduction abnormalities such as Brugada syndrome or other channelopathies, metabolic disturbances, particularly those in electrolytes, toxic ingestions. There are a number of poisonings that can produce cardiac arrest, and there are other non-cardiac conditions that can lead the heart to stop. When we look at the epidemiology of cardiac arrest, in the United States, we have about 500,000 arrests per year. Of those, about 60% occur outside of the hospital, and for out-of-hospital arrests, there's only about a 10% survival rate, although that number does go up to 30% for cases which are witnessed by bystanders and the victim receives rapid CPR. About 200,000 of these events, or about a little more than a third, occur inside of the hospital. And in the hospital, we have a 20% survival rate, which is double what we get outside of the hospital, but it's still really not great. Obviously, that survival is going to be affected by the etiology of the arrest, the hospital itself, how prepared it is to deal with high acuity events, and believe it or not, the time of day. As far as the epidemiology goes, the incidence of cardiac arrest increases linearly with age. So as you get older, you have a higher and higher risk of having an arrest, and 57%, or almost 2/3 of the patients, are men. When you look at the cardiac rhythm in patients with cardiac arrest, about a quarter have either ventricular fibrillation or ventricular tachycardia, which are known as the shockable rhythms. Among those patients, you have about a 30% survival rate. The remaining rhythms, which are pulseless electrical activity and asystole, only produce about a 10% survival rate. So there's a big difference in how likely you are to survive based on what type of rhythm your heart goes into at the time of arrest. Overall, shockable rhythms represent a minority of arrests, only about 25%, but 3/4 of patients who survive have shockable rhythms. So you are much, much more likely to survive a cardiac arrest if you have ventricular fibrillation or ventricular tachycardia rather than one of the other 2 arrest rhythms. When you see somebody in cardiac arrest, they are invariably 100% of the time unresponsive, pulseless, and most commonly apneic, although a few will have preserved agonal respirations or gasping. When you're evaluating an unresponsive patient, you want to always get help right away. Not every patient who's unresponsive is in cardiac arrest, but you should assume the worst case scenario. Assume that your patient is in cardiac arrest and that you need immediate backup. And even if your patient doesn't turn out to be in cardiac arrest, it's never a bad idea to get help because the things that make you unresponsive are never good. Once you have help on the way, The next question you want to ask yourself is, does this patient have a pulse? This is why in cardiac arrest, we don't use the old ABC mnemonic that we talked about in prior lectures to assess the patient. We use CAB, circulation first, because the first and most important question is whether or not your patient has a pulse. We want to check the pulse for a maximum of 10 seconds, always in the carotid. And if at the end of that time there either is no pulse or we have any question as to whether or not there's a pulse, we're going to go ahead and initiate CPR. Only after we've decided whether or not a pulse is present are we going to worry about airway and breathing. So while you're checking the pulse, you can look for clinical evidence of respiration. Again, sometimes you'll see agonal breathing or gasping, and rescuers often mistake this for normal breathing, but you should never see normal rhythmic breathing in a cardiac arrest. If you do, you should rethink whether or not your patient is really in cardiac arrest. So like I said, your most important question is whether a patient has a pulse. We're going to assess that by palpating the carotid pulse. The reason we go for the carotid is in shock, this is the last pulse to go. So patients who are hypotensive but still do have spontaneous circulation might lose their radial or their femoral pulses, but they're always going to keep their carotid pulse up until the last moments before they cease to have circulation. Once again, you get a max of 10 seconds. If you don't clearly detect a pulse in that time frame, start CPR. You're never going to hurt a patient by performing unnecessary CPR, but you will absolutely hurt people by withholding CPR when in fact they don't have spontaneous circulation.
Questions po? Questions, guys? For we are about to end na our ACLS. And then before po i-end ang ACLS, you'll be having the the post-test na po ng ating ACLS. We pump admin. Are you there, ma'am?
Yes po, Sir Mark.
Yes, ma'am. Hi, ma'am. Magpaano na po tayo, ma'am? Magpa-exam na po tayo sa kanila. And then mamayang 1 o'clock po mag-aano po tayo. We will be having the basic first aid. No, so yun po yung topic natin later. So at exactly 1 o'clock. So I'll see you guys at exactly 1 o'clock. I-charge po ang mga gadgets, no? I-refresh lahat ng mga Wi-Fi, ng mga internet connections po nila. Ayan, so yes, after this, now after your exam, magla-lunch na po kayo. So thank you po for listening. See you later. Nasa chat box na po ang ating ACLS exam. Do great in your ACLS exam.
Hello po, yung mga hindi pa po nagsisend ng names, pasend na lang po sa chat room. And yung mga gusto pong mag-avail ng hard copy, 200 pesos po. Free shipping na po siya. Thank you.